Hello, good evening. I welcome all of you for the today's program. Today, our topic is blood and urine report interpretation. Previously, we have done two workshops. The first one is 2 days workshop on veterinary dermatology and cardiology. With Vinod Kumar sir. Then we did one online webinar with Sudhish Nair sir regarding canine behavioral psychology. Today is our third program. Today also our speaker is a well-known person to Sri Lankan vets. He is the one who did our first program. So he is a very busy person because he's building a very large hospital in Kerala, and he's due to this his hospital works he is very busy, but however he managed to get a time for our webinar. Thank you very much for that. And before starting the proceedings, there are a few announcements for the participant. You have to keep your microphone mute all the time, and if you have any question you can post it into the chat box, or you can directly ask that question from the speaker at the end of the program, or you have another option, you can post that question into our event WhatsApp group also. So I am not going to tell much about our speaker, you already know him very well. So I cordially invite our guest speaker, Dr. Vinod Kumar sir, to start the program. We will provide the recording later, so don't worry about that. And if you have any question, you can type it in the chat box. That's better, because during the lecture, do not turn on your microphone. So now I think, and also today's webinar is very, it takes some time, maybe up to 3 hours. We actually plan to have it around 3 hours. So we'll start now. I will invite Vinod sir to start the webinar.
Yes, sir. Yes, sir. So thank you, Dr. Mahesh, for introducing very nicely. And I welcome all of you, my dear friends, all my friends from Sri Lanka, and my friends from my own country, India, and all others from elsewhere, all other parts. So this hematology, blood biochemistry, etc. I have taken webinar, seminar, etc. several times in several places. This is not the first time. So let me start, because I don't want such introduction, too long introductions, etc. And all of the doctors viewing this webinar are very much acquainted with hematology and blood biochemistry of dogs and cats, small animals. So I have split the full portion into three: the hematology of dog and cat, blood biochemistry in the dog and cat and its interpretations, then urine biochemistry and its interpretations. Let us go to the first part, that is hematology of dog and cat. And हर लोगों को स्वागत. So let us say all these things are very basic things. I just hematology and blood biochemistry of dogs and cats, small animals. So I have split the whole full portion into three: the hematology of dog and cat, blood biochemistry in the dog and cat and its interpretations, then urine biochemistry and its interpretations. Let us go to the first part, that is hematology of dog and cat. And हर लोगों को स्वागत. So let us say all these things are very basic things. I just brush up all those things. Functions of blood. It is just transportation of oxygen from the lungs to the tissues and from back the tissues to the lungs, so that everybody knows. Then transport of nutrients. So we have the enterohepatic circulation, we have the enteric villi, and through the enteric villi, everything is being absorbed. Nutrients, we have 5 nutrients, is protein, fat, carbohydrate, minerals, and vitamins. All these are being absorbed, assimilated, and being taken for utilization by the blood to each and every part of the body. So transport of nutrients, transport of metabolic waste products. See, after metabolism, so many waste products are formed. For example, after protein metabolism in each cell, urea is produced, uric acid is produced. Uric acid is a toxic metabolic waste product. It is being transported from the tissue to the liver by the blood only. Ammonia. Ammonia is another end product which is very dangerous, very poisonous end product. It's again transported from the tissues to the lungs. It is being expired. And some ammonia is being transported to the lungs, so that to the liver, converted to urea, etc. So transport of metabolic waste products. Control of water content of cells and interstitial fluid, everybody know, because blood itself is a fluid. Then regulation of body temperature. Of course, when there is increased body temperature, the surface circulation increases, and the peripheral circulation increases, so that the blood vessels of the peripheral organs will be dilated and there will be flushing. So there will be increased blood circulation to the peripheries, and thereby there will be exchange of body heat from the interior or the core of the body to the outside of the body. So regulation of body temperature. Well, just opposite to that, if you go to cold climates, everything will be shrunken. The peripheral circulation will be reduced. And so there will be no too much of heat dissipation. The maximum heat which is produced inside the body during metabolism will be conserved in the body only. Then distribution of hormones. Of course, we know hormones, these are all glands. We have endocrine glands and exocrine glands. The main difference is exocrine glands are having duct and endocrines are having no duct at all. We have some endocrine glands, we know very well. Our pituitary gland, our pineal gland, thyroid, parathyroid, pancreas, all those things, endocrine pancreas. So all these organs have no duct, and this is the hormones produced from these organs, these glands, are being directly taken up by the blood and distributed to the target organs. Defense of the body against bacterial invasion, of course, you know very well. A lot of cells are there, all lymphocytes, monocytes, basophils, etc. are there. The first line of defense, that is the neutrophils, etc. are there. Then that is the immunity itself. Then we collect blood. This also no need to explain, from the cephalic vein in the forelimb, saphenous vein in the hind limb, jugular vein, ear tip. Ear tip, we do not collect too much of blood. We want to examine for a peripheral smear. We want a peripheral circulatory drop of blood. We can collect it from the ear tip. For example, for the detection of trypanosomes or the detection of microfilaria, we used to collect it from the ear tip. Then from medial thigh vein, especially in the cat. Medial thigh vein is very prominent. And the eye puncture in lab animals, sometimes, for example, in the case of a small mouse, we cannot uh, search for a vein, a prominent vein. So by eye puncture, or the tip of the tail will be cut, a slicing will be done, and thereby
Excuse me,
bleeding
sir.
occurs and the blood is
Excuse me, sir.
secreted. Yes,
Sir,
yes.
could you please increase the volume a little bit? There's a
Okay. Okay. Let me. Hello.
I think now okay, sir.
Now, yeah, what happened?
Is it okay now?
Yes, yes,
okay,
it's
sir.
okay with me, but few people posted in chat box, volume is low.
Okay.
Yeah,
How
okay.
about
Now
now?
they said it's
How?
now it's okay, sir.
It's okay now.
Yes, yes, yes,
Okay. Thank
yes.
you.
Please continue, sir.
Yeah. So in the lab animals, we collect it from the ear tip. Sorry, the puncture of the eye. For example, in the case of a small mouse, we cannot find a prominent vein. There we collect it either from the direct cardiac puncture if you want too much of blood, because a mouse which is weighing just 50 grams or 30 grams, we cannot take out too much of blood. We cannot draw too much of blood. So the maximum amount may be 1 ml or so. So we will have to collect the blood from the right source. So sometimes, mostly, I have seen it several times, collecting by cardiac puncture. If we want just a simple drop of am I audible now?
Yes, sir, yes.
Okay. Then cut at a small cut at the ear, tail tip, then puncture of the eye, etc. For that, when we are collecting the blood, sometimes we need the whole blood. So sometimes we need the serum. For collecting the whole blood, of course, the blood should not clot. For that, we have to use anticoagulants. And these are the commonly used anticoagulants, like Heller and Paul's double oxalate mixture. Here we are using two oxalates. That is known as a double oxalate mixture. And we are very commonly using EDT, that is ethylene diamine tetraacetate, then heparin, sodium citrate, then citric acid with dextrose, citrate with dextrose, etc. So acid citrate, dextrose, ACD bags are very commonly available. Sodium citrate also can be used. Then there are certain limitations with this thing. Heller and Paul double oxalate, it contains oxalate, it contains ammonia, it contains NH3 group, and so this cannot be used for the estimation of serum ammonia or blood ammonia or plasma ammonia or blood urea nitrogen, blood urea, creatinine, etc. All these are, NP and non-protein nitrogenous compounds. And so oxalate contains nitrogen. It will hinder, or it will definitely error occurs. And another thing is that EDTA. EDTA, the action of EDTA itself is by chelating the calcium in the blood. So if the calcium, there are 13 clotting factors in the blood. And one of the clotting factors is the blood, this calcium itself. And if we use EDTA as an anticoagulant, if we want to estimate calcium in that blood, but generally we don't use to because we always use clotted blood for that. So it is always, it is unused, it is not used. And so these are the anticoagulants which can be commonly used. And coming to the blood, we all know the blood cells. The blood cells are of three types. The blood has the cellular portion, that is a solid portion, as well as a fluid portion. The fluid portion is nothing but the plasma. The cellular portion contains the three cells, that is red blood cells or the erythrocytes, white blood cells or the leukocytes, and the platelets or the thrombocytes. And the leukocytes or the white blood cells are broadly divided into two. Some leukocytes have cytoplasmic granules. They are not the granulocytes. And some doesn't have the granules. They are known as egg granulocytes. We all know which are the granulocytes. So the granulocytes are those leukocytes which contains granules in the cytoplasm. They are the neutrophils, basophils, and the eosinophils. Then the leukocytes which doesn't contain granules, known as agranulocytes. They are the lymphocytes and the monocytes. You all know all this. This is the same thing, granulocytes, neutrophils, eosinophils, and basophils. Agranulocytes, the lymphocytes, and the monocytes. Okay. Let us take erythrocytes. Actually, all those things, all these cells are derived from the bone marrow. So if there is no bone marrow functioning, no blood cells will arise, no blood cells will come out, no blood cells will mature. So all those blood cells, erythrocytes have erythrocyte linocells, leukocytes have the leukocytes linocells, and the thrombocytes have thrombocytic series linocells. And the erythrocytes, they start as a primordial erythroblast. Leukocyte, they start as a primordial leucoblast. Then platelet, they start in the bone marrow as a primordial megakaryoblast. So everything, all these cells start as very small precursor cells. So erythrocytes, they are derived from the erythroid series of or primordial cells in the bone marrow. They are known as the primordial erythroblasts. They are erythrocytes are biconcave cells. They store hemoglobin, involves oxygen transport, and sometimes they are let free, or they are coming out from the blood vessel. Immediately they will clump together. They will pile together, one upon the other. They will pile together. This is known as rouleau formation. And rouleau formation is the highest. Rouleau formation is forming according to a rate. The rate of rouleau formation shows how much is the erythrocyte sedimentation rate that we are coming. These are the normal erythrocytes. Normal erythrocytes are biconcave in nature. They have a mild central pallor, and there is a slight difference in human beings. The central pallor is less. There's a slight difference is there, and so, but it's a very, very slight differences in size is there between the human erythrocyte and the canine erythrocyte. Then in center of this is the blood stream. In center, you can see a neutrophil, beautifully stained one. And decreased number of erythrocytes is anemia. So this term anemia is wrong. I've seen the Merck veterinary manual, it is said as hypemia. Actually, anemia, ema means blood. Anemia, no blood. So it is anemia, there is no blood, there is no such condition. Without blood, the animal or human being cannot survive. So it is not anemia, it is hypemia only. So what we are telling, generally we used to tell this term anemia. Actually, it is hypemia. So it is, if there is reduced number, it is commonly known as anemia. If there is more number of erythrocytes, we say polycythemia. And poly means more. Cythemia, polycytha. Cytha means cell. Cythemia, cells in the blood. See, polycythemia, it is relating to the red blood cell, increased number of red blood cell. The polycythemia, see this polycythemia are of different two types. The polycythemia is different two types, that is relative polycythemia and the absolute polycythemia. Relative polycythemia means whenever you go to any place, suppose you are going to the Himalayas. So suppose in the Himalayas, it is a high altitude place, and the oxygen tension there, the atmosphere is too low. In such a place, when you go there, the oxygen demand will become more. Oxygen demand becomes more. So from where the oxygen is coming? See, the oxygen demand is more, but atmospheric air has only less oxygen. Somehow the body has to survive with the limited quantity of oxygen. For that, what will the body do? The body will immediately send more number of erythrocytes into circulation, so that these erythrocytes can carry as much as oxygen from the atmosphere. That is a compensatory mechanism by which the body is sending too many number of erythrocytes. Transit is a temporary phenomenon into the bloodstream. It is known as a relative polycythemia. When you come down from the high altitude, all the cells will be withdrawn, and the number of cells become normal. That is relative absolute polycythemia. Relative polycythemia means due to a malignancy, more number of erythrocytes will be produced. For example, there is a malignancy known as polycythemia vera. It's a malignancy. It's a blood cancer where there is enormous number of RBCs. So that is polycythemia. It's an increased size of individual RBCs, macrocytosis. This will come because we all know about MCV. MCV will increase if there is macrocytosis. When it increases, when there is more demand of oxygen, there is too many number of erythrocytes, but at the same time, it has to consume more amount of oxygen. So immediately, there is a disease process is going on. The tissue oxygen demand is too much. From the atmospheric air, they have to grab more amount of oxygen as much as possible. So they will increase in size and they will grab as much as amount of oxygen and carry this oxygen to the damaged tissue. So that is macrocytosis. And decreased microcytosis, because somehow there is a hemolytic process going on. When hemolysis occurs, the hemoglobin inside the RBC will be flown off because due to the lysis of the erythrocytes. And there will be definitely decreased amount of hemoglobin in individual erythrocytes. That we say the MCH is low. In such, when there is decreased amount of hemoglobin inside the erythrocyte, what will happen? It will shrink down. This is known as microcytosis. So if there is macrocytosis, it means that the MCV is more. That means a severe inflammatory or disease process is going on. But if there is macrocytosis, it shows that severe destruction of RBCs are going on. That is, a hemolytic disease is going on. Then increase the color of individual RBCs, polychromasia. Yes, more amount of hemoglobin is being pumped into or stored inside the erythrocyte. We say hyperchromasia, polychromasia. Likewise, opposite thing, decreased color is hypochromasia. Hypochromasia always indicate anemia or hypemia. Difference in size is anisocytosis. Difference in size and difference in shape occurs. Difference in size between individual erythrocyte is known as anisocytosis. This very commonly it is seen in hemolytic disorders, especially in immune-mediated hemolysis. Then also, when there is difference in shape, sometimes round, sometimes cylindrical, sometimes teardrop shape, all these things, sometimes ellipsoidal. So those irregular shapes can be observed. These, that is poikilocytosis. Difference in the shape is poikilocytosis. Difference in the size is anisocytosis. So anisocytosis and poikilocytosis both are attributed to anemia or hypemia. The disease process is going on. Let us examine some abnormal erythrocytes. Acanthocytes is very common. Acanthocytes. See, especially when acanthocytes can be seen in chronic kidney diseases. Whenever you, I have seen this several times. Whenever you examine the blood smear of a chronic kidney patient, you can see this acanthocyte because of the shrinking of the individual erythrocyte. Due to this shrinking, the shrinking occurs because the plasma contains more amount of salt. No, the kidney is actually filtering all these salts. So the kidney is unable to filter all this salt. So what happens? The plasma becomes more concentrated. Generally, we can see that there is the law of osmosis says that fluid will be moving from the area of low osmosis to the area of high osmosis. That means from inside the RBC, that is a fluid in the hemoglobin, will be moving outside and the RBCs will shrink up and attain this star shape. Cones or horns will arise. It's so typical in a chronic kidney disease patient. So also in hemangiosarcoma, in chronic liver diseases, in disseminated intravascular coagulopathies, like these are immune-mediated diseases. Iron deficiency anemia also this can be seen. Acanthocytes. So if more acanthocytes are seen, we say as acanthocytosis. It is a very serious condition. Then Barr cells, almost the same as acanthocytes, but if you examine the periphery of the cell, you can see there are no cones or horns like that, but the periphery will be wavy in nature. They are known as Barr cells. Sometimes Barr cells occur as artifacts. If one or two Barr cells or 3 or 4 Barr cells are found in a blood smear, need not worry, just leave it, ignore it. Then drugs such as furosemide, doxorubicin, etc. can produce Barr cells. Hypokalemia, dehydration. Here also the same thing in kidney diseases, Barr cell also can form. Then in snake bites, generally kidney disease occurs and Barr cells are very common. Dacryo means teardrop. Dacryo means teardrop. Dacryocyte means teardrop-like cell. See, this is a teardrop-like cell. Here you can see teardrop. It is a clear indication of IMHA, immune-mediated hemolytic anemia. See another teardrop cell. If you see more than two dacryocytes in a single smear, it's a clear indication of IMHA. And also iron deficiency, it occurs. IMHA should have to be considered in dacryocytosis. These are helmet cells or keratinocytes. So otherwise known as codocytes, helmet. These are due to schisis or splitting up of the erythrocytes during erythrolysis. If you see helmet cells, simply we can say that these are due to ongoing intravascular erythrolysis. Ovalocytes or elliptocytes. Actually, if you look at the blood smear of a camel, IPAC, then a camelid, then all these animals, you can see ovalocytes. Ovalocytes are normal, oval-shaped cells. Erythrocytes are normal. These are otherwise known as elliptocytes, are normal in camels and camelids. So if you see in other animals, if you see ovalocytes, it shows an ongoing anemic process. See, it's a clear indication of anemia. The cause of anemia, we'll have to find it out. Sickle cells. Just to show you the sickle cell, that is all. And sickle cell anemia is not seen. As in humans, it is a genetically inherited disease, but in animals, sickle cell anemia is not seen. But sickle cells can be seen sometimes. These are all due to erythrolysis. And that is drivenocytes. And this is very commonly seen, as usually seen in deers and antelopes. Then spherocytes. This is very important. Spherocytes. Presence of more than 2 spherocytes in an erythrolytic animal or the erythrolytic blood smear. If you look at the blood smear, these are all spherotypes. You know, just like sphere, there is no central pallor, just like a sphere disease. Here there you can see a normal erythrocyte, you can see a central pallor. This is not a normal erythrocyte because central pallor is large. And so that itself shows that it is anemic. And so anisocytosis is also there, anisocytosis. You can see difference in the size. And these are all spherocytes. This spherocyte. So if you see in the spherocyte, there is no central pallor, and you can say that it is so classical to immune-mediated hemolytic anemia. So whenever you are thinking about hemolytic anemia or jaundice due to hemolytic anemia in a patient, you will have to think about examining the blood smear for dacryocytes and spherocytes, so that if you find any of these, you can say that it is IMHA. See, these are all tests which we can use in the field. See, going after IMHA and going for that is autoimmune hemolytic anemia, that the anti-nuclear antibodies, N, etc. It is a very big laborious process, and no labs are there where these tests are doing. So we will be in a trouble and we will be in a puzzle. And so this small tests we can do, and we can say that it is IMHA. Stomatocytes. Commonly, this is very common in miniature Pomeranians and miniature Schnauzes, and sometimes due to artifact formation also this can. But stoma means mouth. Sometimes you can see that all the erythrocytes are smiling at you, laughing at you, like that. So these are known as stomatocytes, and stomatocytes are so classical to anemia. The cause of anemia, we'll have to find it out. Leptocytes or target cells or codocytes or Mexican hat cells. Again, Mexican hat. These are all anemic processes by which central pallor is lost, but a peripheral pallor we can see. And this is so classical to iron deficiency anemia. So if you see Mexican hat cells, see, in our clinical practice, is it possible always to estimate the iron and say it is iron deficiency anemia? And another thing is that iron deficiency anemia is not so common in dogs, but it is very common in piglets. So we are not dealing with piglets. We are dealing with dogs and cats. So in dogs and cats, if you are looking for the blood smear like this, and if you see codocytes or leptocytes or Mexican hat cells, you can say the anemia is due to iron deficiency. This is poikilocytosis, a difference in the shape of individual erythrocytes. Here you can see the dacryocyte, here a cylindrocyte, another cylindrocyte, one dacryocyte here, this is cylindrocyte here, this is an elliptocyte, then this is a normal blood cell, this is a cylindrocyte, all those things. You see, all those things are there. It shows that ongoing anemic process is there. This is anisocytosis. You can see the difference in the size of individual erythrocytes, and you can see the less number of erythrocytes in the smear. You can see a nucleated RBC. So this is basophilic stippling or punctuate basophilia. See, these are the remnants of the body, remnants of the nuclear bodies, which can be seen in the peripheral smear. If you see one or two punctuate basophilia in the blood smear is admissible, but if you see extensive basophilic punctuation, then definitely it is a sign of severe anemia, ongoing anemia. Otherwise, in such cases, you may not be able to appreciate the central pallor. Sometimes all the other individual erythrocytes will be normal in shape, structure, and color, etc. But sometimes you may see this basophilic punctuation only. In such cases, you will have to see that ongoing anemic process is there. Sometimes it may be hidden also. Those are due to some defective multiplying phases. Hill's body, this is what we are exercising very commonly. because Heinz body anemia, especially in cats, after paracetamol injection of paracetamol consumption in the cat, Heinz bodies are formed, and Heinz body anemia is very common. And Heinz bodies are a precipitation or oxidized hemoglobin, or this is known as oxidative injuries, can be seen as a round globule on the periphery of the individual RBC. And this is very commonly seen in dog after onion poisoning. See, there are certain things which should not be given to the dog. Number one is chocolate, we all know. Number two is onions, whether it is big onion or small onion or garlic. All these things should not be given to the cat, to the dog. So also dates, grapes, avocado fruit, etc., etc. Everybody know all these things. We have to teach our the client. So client may be asking, sir, can all the food be given to the dog? No, no, no. This is the thing. These foods should not be given. So onion poisoning can lead to Heinz body production, and Heinz body will destruct the individual erythrocytes producing Heinz body anemia. These are Heinz bodies or a blood smear individual erythrocytes. You can see the Heinz body. See, when you are looking for the first time, sometimes you may think that these are all some vector-borne organisms. It can be anaplasma in the bovine, or it can be Babesia gibsoni. So don't get confused, because you can see as raised surface particles. See, here also you can see raised surface particles. Here also you can see. So otherwise, if it is Babesia gibsoni, you can see only inside the cytoplasm. Onion poisoning can produce Heinz body anemia. Then Howell Jolly bodies are nuclear remnants. Nuclear remnants are very commonly found in animals with anemia in all species, whether it's a cat or a dog. The purplish, dark staining round particles. If such Howell Jolly bodies are found, see, sometimes we get confused when we are looking for the first time Howell Jolly bodies, then anaplasma, Babesia gibsoni, all those things look like similar. So this can be achieved only by continuous exercises. So if you see Howell Jolly body, it clearly means that an ongoing anemic process is the ongoing anemic process. Cabot's ring is also a remnant nucleic acid which are present due to a defective multiplication phase. And so it doesn't mean that it produces any issue in the dog's health. These are hemor bodies, most pigments containing iron. A defect due to defective iron metabolism. Sometimes these iron pigments can deposit into the erythrocytes producing hemosiderosis. And this is siderin pigments. And these cells are known as siderocytes. And siderocytes definitely, as when time goes on, siderocytes will undergo lysis. And so if siderocytes are more, extensive erythrolysis occurs. So this happens when there are enzyme inactivation during the phase of conversion of the ferric form to ferrous form. It's not so common in animals, but sometimes it is seen in human beings. As what I said in the Roloff formation, when the blood is coming out of the blood vessel, it immediately piles up. This is known as Roloff formation. This Roloff formation is very quick in equines, in horses, and so as quick as the Roloff forms, as quick as all the blood cells will settle down. So Roloff formation is directly proportional to the ESR. That is why the Roloff formation is very quick in equines, and the equines have a very high ESR. The Roloff formation is extremely slow in the bovines and the caprines, and so in the bovine there is no ESR at all. If you take the blood of the cow and keep it for one day, it will not settle down. Maybe it settled down by at a rate of 1 millimeter per 24 hours. So that is rouleau formation. So this has to be differentiated from agglutination. Agglutination occurs as when there is an immune reaction. So this is agglutination. You can see there is no piling up. It's all clumping up. It's not piling. Piling means one above the other. This is not one above the other. This is clumping. This is agglutination. We can see it from the low power of the microscope itself. Those were something about the erythrocytes. Then comes the leukocytes. Leukocytes are derived from the leukoid series of primordial leukoblasts of the bone marrow. So the neutrophils will be the first formed cells. Neutrophils will be the first formed, and then the immature leukocytes, when inside the bone marrow, they'll be immature and they'll be having a band shape. We say the immature leukocyte of the band cell neutrophil. The band cell leukocyte. Mature leukocytes will, mature neutrophils or mature leukocytes will be, mature neutrophils will be having a lobated nucleus that we'll see later. There is no affinity. So why they are said neutrophils, the leukocytes? Why the first form is a neutrophil. Why they are said neutrophil? Neutrophil because they will not have any affinity towards the acidic stain or the alkaline stain. Then some of them transform to the cells with coarse acidophilic granules in the cytoplasm. The granules will be going thicker and thicker, and they form eosinophils. They contain a little quantity of histamines and serotonin, and will be remaining in the circulation. They are termed as eosinophils. Later, they get lodged in the vascular endothelium, forming mast cells. They'll be sticking onto the vascular endothelium, known as a mast cells, and sometimes they'll be dislodging and found free to the tissues. They'll be creeping outside the blood vessels and creeping through the tissues because they have pseudopody. They are known as plasmocytes or plasmocells or macrophages. They are completely involved in allergic reactions and phagocytosis because they move very quickly. From some of these cells, granules will be lost and found in circulation known as monocytes. At last, monocytes will occur as a latent phase of leukocyte formation. Some of these granules will be lost at last from the plasmocytes, and then they will be forming as monocytes and be found in circulation, but very few in number, monocytes. Lymphocytes are separate entity. Lymphocytes are separately produced from the bone marrow. They are released in the circulation as inactive cells. And lymphocytes, as when they are released to circulation, the lymph node will catch these lymphocytes, and the lymphocytes will be trapped in these lymphocytes and then will become activated. That is for the humoral immunity. And then they will be released in the blood circulation known as the blood lymphocytes, or we say generally as a B lymphocyte. And some of them will be trapped inside the lymph nodes and be kept permanent. They are known as T lymphocytes or thymic lymphocytes. And the lymphocytes, they carry specific immunoglobulins. We all know they are the second line of defense. The first line of defense is nothing but the neutrophils. So the lymphocytes carry specific immunoglobulins for humoral immunity. Lymphocytes also act as a first line of defense in most of the bacterial diseases, but mostly in malignancies, immune-mediated diseases, and some viral diseases. See, there was a thought early. If there is increased number of lymphocytes, it is a viral disease. If there is an increased number of neutrophils, it is a bacterial disease. Actually, it is not true. I also thought that it was true, but it is not true. Whenever there is neutrophilia can occur in both the viral as well as bacterial diseases. But when time goes on, the neutrophils will be insufficient to neutralize the effect of the antigens produced by the virus. So for that, humoral immunity mechanism will become more active, and so the lymphocytes will come to counteract. Later on, interferons will take the charge. We all know that. So in bacterial defense mechanism, the first line of defense itself is the neutrophil. And the neutrophil, when they go they fight and die. And when they are mixed with some exudates, we call it as pus. Why pus is white in color? Because it contains innumerous dead leukocytes, these neutrophils. That is why. Then there are certain terminologies in hematology like leukocytosis, coming to the leukocytes. Coming to the RBCs, we learned so many terminologies. Here in leukocytes, we know leukocytosis, leukocytopenia, leukocytosis, increased number of leukocytes. When an insult comes into the body, the bacteria attacks the body, immediately first what will do? Immediately within 2 minutes, the leukocyte or the neutrophil will not come. They cannot come. They will wait for some more time because they have a chemotactic mechanism is there. From there, a messenger will come and they will tell the body immune mechanism, then only the immune mechanism will work out. There are so many processes. So by this time, what will do? The bacterial organism, they will multiply enormously. They will invade the first line of defense. And so that a peracute infection occurs. And during that time, the first line of defense is completely killed off. Thereby, a leukocytopenia occurs in the first peracute form. Then only after 24 hours, the body immune mechanism will sense that, see, the organism which is coming from outside is so powerful, we have to send somebody who will be able to fight more. So they will, the immune mechanism, the bone marrow will send too many numbers of neutrophils or leukocytes to the area of insult. So what will happen? There will be increased number of leukocytes in the blood. That is leukocytosis or neutrophilia occurs. But sometimes the defense mechanism may be told by the defense mechanism itself will tell that the released number of neutrophils or the leukocytes is insufficient for killing the microorganism or for making a battle. So what will happen? The immune mechanism will ask the bone marrow to send even the babies out. Even the babies out. Who are the babies? The immature neutrophils. So the immature neutrophils will be sleeping and playing inside the bone marrow. Immediately they will be called up. Come on, my dear babies, come on. All the babies come on and have this. They all be provided with revolver and guns. Go and fight. So they are getting this for the first time. They are getting this revolver and pistol for the first time, but they will go and fight because there is no other hope. Somehow the body has to fight against the organism which is coming outside from outside. So they will go and fight. So that when you look at the blood during that time, lot of immature blood cells, immature leukocytes can be seen with the band cells. Oh, okay. So for that, what we will say? So the infection is so severe, the body has sent out so many number of immature leukocytes. That is, immature neutrophilia occurred. Immature neutrophilia is otherwise known as left shift or shift to left. Okay. So a shift left are two types: regenerative shift left and degenerative shift left. I'm not going deep into it. Degenerative and regenerative. And degenerative shift left means, okay, immature neutrophils are there, but the mature neutrophils are less number. That is degenerative shift left. That is a very dangerous process. Regenerative means, okay, the immune system is working very well. The number of total leukocytes are very high. So also the number of immature leukocytes are also very high. So it is working very well. That is regenerative shift left. So always when a bacterial infection occurs, a regenerative shift left is always good. But if it is a degenerative shift left, it is bad. The neutrophilia, the other terminal neutrophilia, increased number of neutrophils. Neutropenia, decreased number of neutrophils. Lymphocytosis, lymphocytopenia. Eosinophilia, eosinocytopenia. The eosinophils is more, especially if it is having a very big worm load. If it is having a type 4 immune reaction, severe urticarial disease, chronic allergic dermatitis, so eosinophilia occurs. Then monocytosis in chronic diseases, for example, jaundice disease in bovines, tuberculosis in dogs. So all this monocytosis occurs. This is a mature neutrophil. Here you can see the lobated, the different lobes of the nucleus. That's a mature neutrophil. So here you can see the There is no lobes. It is an immature neutrophil. Here also an immature neutrophil. And lobes are absent. In eosinophil, this is a second phase of formation of the neutrophil. You can see the coarse acidophilic granules. You can see the lobulated nucleus. The coarse acidophilic granules is these acidophilic granules contains histamine and serotonin for combating allergic diseases. The basophils are having slight these granules are also there. But a bluish tint also can be seen. That is a basophilic tint. It's not acidophilic, it is basophilic. Basophilic granules can be seen. Lymphocyte, they have no granules in cytoplasm. You can see a cytoplasm here. You can see the big nucleus here. Monocyte. Monocytes have, this is a lymphocyte, this is a monocyte with a horseshoe nucleus. Horseshoe nucleus, so typical. And they have no granules on cytoplasm. Sometimes in some neutrophils, if you look, you can see in some toxic reactions. For example, in the case of heavy metal poison, chronic heavy metal poisoning, etc. You can see some granules can be seen inside the neutrophil like this, immature neutrophil. They are known as toxic neutrophils, or they are known as dolly bodies. Mast cells can be, mast cells are nothing but they are again matured eosinophils only. And mast cells, they are actually lining the vascular endothelium, and when there is an immune reaction or there is an allergic reaction, it will be dislodged. They have coarse granular appearance as cytoplasm. And macrophages have pseudopodial movement, and you can see the pseudopodium or they have to creep, they can change its shape, and they can creep through the intercellular cement substance and also the pores in the tissues. Thrombocytes, platelets. Platelets are derived from the megakaryocytes in the bone marrow. Megakaryocytes are, mega means large, karyo means nucleus, cytes means cell. So large cells with large nucleus, that is megakaryocytes. And megakaryocytes, as when time goes on, small finger-like processes arise from the megakaryocytes, and each finger-like process will detach, forming small nucleated cells which are known as thrombocytes or platelets. They have cytoplasm with the nucleus, and they are involved in blood clotting. We all know that. So here you can see a neutrophil, you can see a lymphocyte, here you can see the platelets, all these RBCs can be seen. Here you can see a neutrophil. Then, when you take the hematological values, the total erythrocyte count is very important. So we count the erythrocyte. So when we are studying in the veterinary college, we were taught how to count the erythrocyte. So in the blood smear, so we have the counting chamber, etc. was there. And nowadays we have auto hemoanalyzer. Just we have to put the blood there, we have to feed the blood, and then the result is coming out. So when there is increased erythrocytic count, it is known as polycythemia. Decrease is known as oligocythemia or anemia or hypemia. And I have mentioned about the physiological polycythemia occurs in environmental hypoxia. This is another thing what we ignore, that is ESR, the erythrocyte sedimentation rate. That is very important. See, I have already mentioned that the speed of rouleau formation, that is dependent, and that always influences the ESR. ESR is dependent on the speed of rouleau formation. And another thing is the specific gravity of the plasma. See, if the specific gravity of the plasma is more, what will happen there to the erythrocytes? The erythrocytes becomes very light, and they cannot sink down. So they cannot sediment down. Or sometimes we can say that they sediment very slowly. due to the increased density of the plasma. If the plasma density is too low, or plasma specific gravity is too low, what will happen? The erythrocytes become more dense. They will sink down or settle down very quickly. Got it? So what happens in a disease process? There are two types of proteins in the blood, in the plasma. We all know the albumin and the globulin. The albumin is more dense than the globulin, and they are in a specific ratio that we also know. And this ratio will be altered. And when there is a disease process, acute or chronic, the globulin level increases. See, the albumin is more dense than the globulin. So what will happen if the globulin content of the blood plasma increases? The specific gravity of the plasma decreases because of the high amount of globulin. The specific gravity of the plasma decreases. And so what will happen to the ESR, or what will happen to the density of the specific gravity of the individual RBCs? The RBCs and all the cells will settle down very easily. That means when there is increased globulin fraction of the blood, ESR is more. Got it? That is why ESR is more in fever. ESR is more in any infection. In any infection, globulin will be produced because globulin is containing only immunoglobulins. There are antibodies. Got it? It is so simple. So that is why ESR is very important. ESR increases as when the disease process or the intensity of the disease process increases. Relay formation is not a feature in 2 minutes. And so high ESR, generally if a dog is having ESR more than 100, is having generally a bad prognosis. But always keep in mind, generally a bad prognosis, not always. I have seen several times dogs which is having high ESR more than 100 but survived. But if a dog is showing severe clinical signs like a septicemia or toxemia or so, whatever it be, and the dog is too much ill, it is bedridden, and it is having ESR of more than 100, don't give a good prognosis to the owner. It always kill the dog. Got it? So high ESR is giving a bad prognosis. So always take ESR for forecasting a disease process. Then packed cell volume. While you are centrifuging the blood, you will get the packed cell. You centrifuge it at 5000 RPM or 3000 RPM for 5 minutes. After that, you take out the blood. You take the hematocrit tube, and in the top you can see the yellow colored or the straw colored fluid, that is a plasma. In the bottom you can see the packed cell, that is a packed cell. That is that the volume. We have to kind of count the, have to look for the measure the packed cell volume. That is very important. Packed cell volume. If the packed cell volume is low, it means that there is anemia, less number of red blood cells. If the packed cell volume is more, maybe opposite to the anemia, that is can be polycythemia. But on the other part also, if the packed cell volume is more and if the plasma volume is less, you can see there is dehydration. So when there is dehydration, the PCV increases. It's a clear indication. Increased PCV is a clear indication of dehydration. See, in my fluid therapy class, I have said each millimeter of PCV produces 10 ml per kg fluid loss. That I have taught in the blood, fluid therapy class. You remember my fluid therapy class. So, another thing is, in between this top fluid volume, that is the fluid that is a plasma, and the bottom, the packed cell, there is a small white line at the center. That is known as the Buffy cord. That is known as the Buffy cord. So the Buffy cord is the center of this thing, in the middle of these two, the upper plasma and the lower cell pack. So the Buffy cord is also very important. The Buffy cord contains the leukocytes. That Buffy means it's a white cord. It's a white segment. It's very small. It's very small, very thin layer. So it's a Buffy cord. It contains maximum number of WBCs. So if we want to examine the WBCs, we can pour off this plasma, or we can aspirate the plasma. After that, you can just simply touch the Buffy cord, take a small drop, drop it onto the slide, smear it, and you can see only RBCs, only WBCs. That is the efficiency of the Buffy cord. So that if at all there is any organism inside the WBC to be found, for example, hepatozoon canis. Hepatozoon canis is a vector-borne parasite which is found inside the leukocyte. So, for examination of hepatozoon canis, for identification of hepatozoon canis, it is always better to examine the Buffy cord smear. Got it? So, that is regarding. Then the color of the plasma also can be assessed. A normal PCV can be obtained if the patient is anemic and dehydrated. So I already told that if it is anemic, there will be low PCV. If it is dehydrated, there will be high PCV. So if it is in between, if the patient is having severe dehydration plus anemia, what will happen? We'll be having a normal PCV. Very simple logic. So in that condition, we will have to ascertain the patient is very weak. We have to go for other clinical examination and body water assessment in that case. The color of the supernatant plasma is very important, as it shows normal straw colored to deep yellow in icterus, red in hemoglobinemia, and white in lipidemia. Sometimes when you take the blood and allow it to clot, the topmost layer, that is serum itself, may be containing a white color. There is a high lipidemic sample. There is a clear indication that there is a kidney disease. And second chance is a liver disease. The first chance is a kidney disease. So the color of plasma is very important. So this is a Buffy cord. Center portion of the blood centrifuge, white portion full of leukocytes and thrombocytes. See, suppose the white portion, we can identify the white portion, we can see the thickness, we can measure the thickness of the white cord.
ഞാനല്ല ആള് തന്നെ ഓൺ ചെയ്ത് വെച്ചേക്കുന്നത്. ഞാനൊന്നും അങ്ങനെ ഒരു പഠിക്കാൻ പോകുന്നു.
It is somebody from Kerala state only, because they are speaking Malayalam, my language. They were speaking in Malayalam, my native language, my mother tongue. Okay, been muted. Anyway, generally 1 millimeter can extend up to 2 millimeters. See, generally the Buffy cord can be extended from 1 millimeter up to even 2 millimeter. And if it is above 1 millimeter or 2 millimeter or above, is in leukocytosis or leukemia. Generally, it will be 1 millimeter only, the Buffy cord. If it is above 2 millimeters, It occurs in leukemias, generally in leukemias, not even leukocytosis, but some textbooks say in leukemia only. Every 0.1 mm of the Buffy cut indicates 1,000 cells. These are approximate things. Every 0.1 mm indicates 1,000 cells up to 1 millimeter. If it is above 1 millimeter, for every 0.1 mm above 1 millimeter indicates 2,000 cells. So these are an approximate measurements. The real measurement we have to ascertain from counting the number of leukocytes. So this is the centrifugal sample. You can see the supernatant plasma. You can see the decanted cells, that is packed cells. Packed cells comprises 45% in a normal blood sample, and 55% is comprised by the plasma. In between there is a Buffy cut, which is something around 1% of the total blood. So you can see here also the plasma. Plasma contains water, proteins, glucose, and hormones. Here the Buffy cut contains leukocytes and platelets, and the hematocrit, that is the lower portion, that contains red blood cells only. Leukocytes will be here only. These are because erythrocytes are the most dense ones because they contain the hemoglobin, they contain the iron, so they are highly dense. This is a normal blood. What happens in anemia? See, the PCV is low, the plasma is high. PCV is low because of anemia. What happens in dehydration? The plasma is very low and the PCV is high. So the PCV becomes high in dehydration, PCV becomes low in anemia, and normally should having a PCV of 45% plus 55% plasma and 1% Buffy cut. Sometimes if we get a sample like this, you can see the plasma here. You can see as a very low PCV. You can see the packed cell here. You can see the leukocyte which is above 2 millimeters. That's a clear indication that there is leukemia. This is a patient with a leukemia. An assessment of hemoglobin content. Mostly our doctors, they always think hemoglobin can give only the essence of anemia. No. When we are examining a highly dehydrated animal, we can see that hemoglobin is something around 18 gram per deciliter, 20 gram per deciliter, 20 to 23 gram per deciliter, etc. What does it mean? Hemoglobin is always being concentrated in dehydration. So it always indicates dehydration. In dehydration and hemoconcentration occurs, hemoglobin level increases and decreases in anemia, especially in hemorrhagic anemia. We have so many anemia like that. Hemorrhagic anemia, hemolytic anemia, dyshemopoietic anemia, myelophthisic anemia. Myelophthisic anemia means in the bone marrow there are no normal cells. All the fibrous tissue has been taken up and completely filled, and they have replaced the marrow tissue. That is myelophthisic anemia. Then dyshemopoietic anemia means due to lack of erythropoietin or leukopoietin or due to lack of iron, there will be less production of cells. That is dyshemopoietic anemia. Then hemorrhagic anemia, there is blood loss. Hemolytic anemia, of course, we all know this. See, these are the polychromatic erythrocytes. See, when we are discussing about polychromatic erythrocytes, we have to say whether it is spherocytes or not. Generally, spherocytes also occur like this, but spherocytes will be very small than this is a normal erythrocyte. This can be considered as a spherocyte, and spherocytes will be very small, almost 1/2 of the erythrocyte. That is a spherocyte. But here you cannot say that these are all spherocytes, but these are all polychromatic erythrocytes. It happens in dehydration. It happens in increased hemoglobin production. Here you can see there is less hemoglobin. You can see that these are all leptocytes, very thin cells which contain only so you can see the central pallor is very large. So it is very clear that there is severe anemia. In this cell, you can see microcytic hypochromic RBC, nucleated RBC, podocyte, this target cell. All these things can be seen. This is anemia and poikilocytosis and anisocytosis. Everything can be seen in this single smear. And here, just to show you that it's a normal erythrocyte, this is a microcyte, this is a macrocyte, this is an oval macrocyte or oval elliptocyte, this is a hypochromic macrocyte, hypochromasia grade 1, hypochromasia grade C, the central pallor is, here you can see central pallor, 1 plus hypochromasia, 2 plus hypochromasia, 3 plus, 4 plus, and you can see a reticulocyte here. The target cell, spirocyte, all we have seen here. Target cell, spirocyte is very particularly, spirocyte presence can be attributed to IMHA. Then ovulocyte, it shows that there is hemolytic anemia. Stomatocyte, there is hemorrhagic anemia. Sickle cell produces hemolytic anemia. Acanthocyte produces renal disease and hepatic diseases. Helmet cells are schistocytes. Both can be seen in hemolytic anemias. Teardrop cell or dacryocyte can be seen in IMHA. Then Burr cell, this also can be seen in acute and chronic, especially in chronic kidney disease. Burr cells and acanthocytes can be seen in chronic kidney disease. Then these are the mean erythrocyte indices or values. When the PCB is divided by the RBC, PCB is divided by the RBC. So the PCB is divided by the number of RBCs, so that we can say that it indicates the volume of each individual RBC, that is the MCV, mean corpuscular volume. It is very important. We always ignore that portion, the MCV, MCH, etc. This is very important. Just listen very keenly to me. This is MCV. MCV means it is a ratio between the PCB and the RBC. That is a PCB divided by RBC. So that the PCB is divided by RBC, we can see that the individual, so corpuscular, the volume of the individual RBC can be detected by this formula. That is a mean corpuscular volume. Then if the hemoglobin is being divided by the number of RBC, we can say that. So hemoglobin, so you simply listen to it, the hemoglobin, total hemoglobin divided by the total number of RBC. So that what will happen? Inside one RBC, how much quantity of hemoglobin is there is roughly calculated. That is the MCH. So what happens in hemolytic anemia? The MCH becomes very low. What happens in MCV? If there is anemia, MCV becomes more high. Because why there is more high MCV? Because available erythrocytes are trending, or they are working hard, or they are increasing in size to carry maximum amount of oxygen from the atmospheric air and to supply to the ailing tissues. That is MCV. Then the MCH. How much amount of hemoglobin is there inside the individual erythrocyte? Here then, hemoglobin in grams, total hemoglobin divided by the PCB. That means in a total packed volume, in a total number of 100 cells or 1000 cells. So in 1000 cells or 1 lakh cells, how much concentration of hemoglobin is there? That is what is said in MCHC. MCHC is not very important in MCHC is not very important in veterinary hematology, but MCHC also can be considered important. When we are going deep into hematology, we can say that MCHC is also important. But MCH and MCV is very important. So we will come to it. MCV. High MCV. High MCV means macrocyte. My MCV, here MCV. High MCV means macrocytic RBC. And high MCV always indicates B12 deficiency anemia, chronic liver diseases, and hypothyroidism. Okay, these are the major attributes we have to keep in mind. High MCV indicates anemia due to B12 deficiency, chronic liver diseases, and hypothyroidism. And low, that is microcytic RBC, generally in dogs, indicates iron deficiency anemia, then severe hemorrhages and GI bleeding. Okay, got it. Just keep in mind these two things. Then MCH. MCH is low in decreased hemoglobin and lack of dietary iron. A decreased MCH lowers generally in hemorrhagic anemias, but it increases in dehydration. It lowers MCH decreases in hemorrhagic anemia and lack of dietary iron deficiency anemia. But iron deficiency anemia is not so common. And maybe in dogs, it can also happen, maybe poor iron absorption from the gut. That can be happened. Then MCH increases in dehydration, that I have already told. MCH increases because MCH, that is it is substantial. When MCH is high, it indicates that there is dehydration. But we can see other attributes also, like PCV. PCV increases. PCV increases when there is a dehydration. Along with that, you look for the MCH also. If the MCH also increases, it is a clear indication that there is severe dehydration. And when there is low hemoglobin, it indicates hemorrhagic anemia. So these are the four attributes, like low MCV shows decreased hemoglobin, lack of dietary iron, poor absorption of iron from the gut, and increases in dehydration. And MCHC, actually, it doesn't show too much of significance. But if the MCHC is more in a hemolytic animal with anemia, if the MCHC is more, immediately you should think about IMHA. This is very important. So in IMHA, in field conditions, how we can diagnose? You examine the blood smear for bacteriocytes, examine the blood smear for spherocytes, take the the blood parameters like MCHC. MCHC will be high. If these three things are coming and you can see these three things, it's a clear indication in a hemolytic animal that it is IMHA. Because IMHA is very common in dogs. Whenever there is a vector-borne disease, an intraerythrocytic, intravascular hemolytic disease such as Babesia canis or eperythrocytosis, immediately due to DIC, this IMHA also occurs. So you will have to conquer or tackle this IMHA, that is an immune disease process, by the help of corticosteroids. For that, we will have to diagnose IMHA also. So think about these three attributes. And MCHC, otherwise also, if you are going with very high and chronic use of corticosteroids, MCHC itself will increase. And MCHC will be, if high with low MCH means it is a hypochromic anemia, then very commonly it is seen in hemolytic anemia. And high with low MCV means it is microcytic hypochromic anemia, very commonly seen in hemorrhagic anemia. So if it is low, if the MCHC is high with low MCH, it can be hemolytic anemia. And if the MCHC is high with low MCV, it is hemorrhagic anemia. And another very important and a very interesting thing is that MCHC becomes unaltered in dehydration. If you think logically, we can think that MCHC can increase in MCHC can be attributed to dehydration. But the reality is that MCHC becomes unaltered in dehydration. For assessing dehydration, we can go for MCH, we can go for PCV, we can go for total proteins, all those things. Total solids in the blood, it can be used. Then another parameter which we should consider is RDW. RDW is the red cell distribution width. This is very important. Suppose we are not examining the blood for anisocytosis or poikilocytosis. Anisocytosis is more important and very dangerous than poikilocytosis. So, the red cell distribution width is increased in anisocytosis. So, RDW, normally, two types of RDW you can see, the standard deviation RDW and the corpuscular volume RDW. RDW-SD and RDW-CV. We should not consider this RDW-SD, leave it. But the RDW-CV, the corpuscular volume, which directly indicates the anisocytosis. So if the RDW-CV is more, it is directly related to the MCV and significant in canine hematology. Then normally it should be 14 to 19. So the thing is that it should not go beyond 19. Don't go beyond. If it is going beyond 19, even nearing to 19, 16, 17, 18 itself, we can say that the anisocytosis is there. So we'll have to examine the blood for other things, like why there is anisocytosis. Is there Babische canis or Babische gibsoni? You'll have to look for that. So these are all indications. RDW is a clear indication that there is high RDW is a clear indication that there is anisocytosis. And very high, extremely high, that means 25, 26, 27, etc. RDW indicates IMHA. Again, so IMHA we have studied about 4 parameters. Number 1 is presence of dacryocyte in the blood smear. Number 2 is presence of spherocyte. Number 3, high MCHC. And number 4, very high RDW. Okay, 4 attributes we have studied for IMHA. So you should not forget. This is anisocytosis. Why this is anisocytosis again? Here you can see a nucleated RBC. And you can see the poikilocytosis. And the blood smear. The blood can be stained by different stains which are used. Alcoholic stains can be used, such as the Wright stain, Leishman stain, etc. Aqueous stains can be used, Giemsa stain. Then special stains such as Papanicolaou stain also can be used. Then field stain A, field stain B is there. That's also good. That's very easy also. It takes only just 45 seconds to smear the blood smear. Blood smear should be tongue-shaped and so thin. And with this, I am concluding the hematology portion, the blood smear, the hematology portion. Now, thank you very much for listening to my hematology session, and 2 more, the big session is coming, our blood biochemistry session, and you please note down all the doubts which arise during this hematology session, and at the end we are having a discussion session. We will discuss on that. Here my phone numbers are written. Please, anybody among you can call me in 98472-94339. Anybody can WhatsApp to me over 94966-74339. Thank you. I'm moving to the next slide. Next topic.
So if you need any break, 5 minutes break or something. Hello?
Yeah, and everybody is muted. I will have to look the chat.
Sir, can you hear me?
Yes, I can hear you, sir.
So if you need 5 minutes break or something.
I don't need any break. Yeah, all our people are, all our viewers are doing no only.
Okay.
No, they do not want a break. Our people do not want a break. We will directly go to the next session.
So there's a one question in chat box. We'll discuss later, no?
Yeah, we'll discuss where we can find the food therapy class.
No, before that, sir, one person asked that how to select the anticoagulant.
Anticoagulant, I have already told that anticoagulant selection should be very meticulous. That we should normal anticoagulant we can use for hematological uses. We can use EDTA. EDTA is sufficient. EDTA can be used as an excellent anticoagulant in all other tests, except in calcium estimation. But we are not using EDTA for calcium estimation. Otherwise, also in all textbooks it is said only for calcium estimation you should not use EDTA. Otherwise, we can use EDTA. And the same thing, I am also doing this blood test regularly on daily 4 or 5 or 6 blood tests I am doing, and I am using only EDTA.
Okay, sir. Thank you very much.
And now let me go to the other thing. Can you see my PowerPoint?
Yes, sir. Yes.
Now can you see it?
Yes. It's visible, sir.
Okay. So now we are jumping on to the next session, that is diagnostic enzymology. Diagnostic enzymes in dogs and cats, its estimation and interpretation to field condition. Now, all these things I am explaining all these things according to field conditions only. Let us see. See, we have a lot of enzymes. We have CPT, SGOT, CPK, a lot of things are there. So let me introduce something regarding those. Enzyme level reflects organ activity. Okay, we all know. We are estimating the ALT, SGPT level for the liver. We are estimating the acid phosphatase level for the prostate. We are estimating the lipase for the pancreas. Okay, all these things, these are enzyme levels. These are enzymes which reflects the organ activity. So we can say increase in these enzymes or hike in these enzymes in the blood shows degeneration of the target organ. For example, pancreas produces certain enzymes. We know amylase, lipase, some proteases, etc. Lipase is the main enzyme. So if there is very high increase in the lipase level, what does it mean? Oh, it means that the pancreatic cells are distracted and these enzymes, the lipase is being released to the circulation, absorbed in the circulation, and from the circulation, we are taking some blood, we are estimating the lipase level. So the lipase is very high. We can say that, oh, the pancreas is degenerated. There is destruction of the pancreatic cells. So we say there is pancreatitis. So high reflects degeneration. Then low level reflects chronic and complete degeneration. Low level means, see, for example, SGPT or ALT, SGPT. Let me say the old name, SGPT. SGPT increase means the liver parenchyma cells are distracted, and those enzymes which are stored inside the liver cells, parenchyma cells, are being released into circulation. And so we say that there is an acute inflammatory reaction of the hepatic tissue. So there is somehow there is a chronic hepatic reaction, and all these enzymes have become very low. What does it mean? There are no much hepatic parenchymatous tissue to produce this much amount of enzymes. That is why. So low level reflects chronic and complete degeneration. Mostly these enzymes are metabolic enzymes, and these enzymes are situated intracellular. Or otherwise we can say these enzymes can be termed as fingerprints of the certain cells. For example, SGPT. SGPT is a fingerprint of liver. Lipase is a fingerprint of the pancreas. Acid phosphatase is a fingerprint of the prostate. CPK BB, CPK MB, it is a fingerprint of the cardiomyocyte. CPK MM, it is a fingerprint of the skeletal muscle. CPK, BB. It's a fingerprint of the brain. So some enzymes are there, specific enzymes are there which are produced with those cells only. They're not specific enzymes. They can be termed as fingerprints of certain target cells that we are coming. Enzyme units. One unit means enzyme required under given assay conditions to catalyze the conversion of 1 millimolar substrate per minute. Leave it. Normal value is always highly variable. See, whenever we are dealing with the enzyme levels, actually the enzymology, diagnostic enzymology says, rather than the enzyme level, we should say the enzyme activity. And it increases in acute degenerations. No or reduced decrease in chronic degenerations. Then increase in impairment of enzyme excretion, example, ALP and lipase and amylase. See, that also can happen, not only degeneration. For example, alkaline phosphatase. Alkaline phosphatase is an enzyme which is produced inside the bile duct, intrahepatic biliary canaliculi, intrahepatic bile ducts. Those cells which are lining the intrahepatic bile ducts, they produces alkaline phosphatase. So also certain bone cells such as osteoblast, osteoclast, etc. also produces this alkaline phosphatase. So when cells lining the intrahepatic biliary canaliculi produce these enzymes, and these enzymes are released into circulation, released into the bile, and through the bile, for activation, this is coming out into the duodenum. Okay. Well, there is a bile duct flow obstruction. For example, a stone in the bile duct. What will happen? There will be stasis of cholestasis. And all these enzymes will be reuptaken. And the blood level of these enzymes will increase. Can we say that there is a degeneration? No, it is not a degeneration. It is due to the obstruction in the flow part. So that also can happen. The impairment in enzyme excretion. Lipase. Lipase is being produced by the exocrine function of the pancreas. And it is being flown to the duodenum via the bile duct. If there is a bile duct outflow tract obstruction, obstructive pancreatic disorder, there will be reuptaking of these lipase, etc., producing hike in the lipase in blood. So there is impairment in the enzyme excretion. Then non-specific increases of certain enzymes are also there. For example, in the young ones, in young animals, the infants, etc. Bone development is so fast. So osteoblastic and osteoclastic activity is very high because chondrogenesis, mineralization, osteogenesis, all these processes needs lot of energy and lot of minerals. During these processes, there will be excess activation of osteoblasts and osteoclasts, so that osteoblasts and osteoclasts produce more amount of alkaline phosphatase. So in young ones, infants, growing bones, in growing animals, alkaline phosphatase level is normally high. Got it? That is true. It is normally high. So we should not take the alkaline phosphatase level of the 3-month-old pup. It is high, and we should not say that there is a hepatic disease. That is what I was telling. We should not tell that. We have to consider this meticulously. We have to find it out. Then certain chemicals can increase certain enzymes. Barbiturate injections. We were using thiopentone sodium. We are using anticonvulsants such as phenobarbital, pentobarbital, secobarbital, etc. All these things can induce increased alkaline phosphatase level. Then alcohol itself in human beings can increase the GGT level. Then RBCs in all animals, dogs, cattle, humans, etc. RBCs contain a lot of SGOT, that is AST. And when there is hemolysis, erythrolysis, this SGOT will be released. It will be uptaken into the circulation, producing hike. That is a non-specific increase. And decreases. Decrease is not much useful. It can be an error. If you store, suppose today you are taking some blood, clotted blood. You are keeping it inside the refrigerator for 3 days. And after 3 days, you are taking it for estimation of SGPT, SGOT, etc. What will happen? The enzyme level will be very low. Why? Because enzymatic degradation occurs. Whether it is refrigerator or not, it may withstand up to 6 or 7 hours only. Beyond that, it cannot withstand. All these are proteins. Denaturation occurs. Pinpointing certain degenerations. Only few organs are organ specific. For example, ALT or SGPT in dogs, cats, and human beings, they're highly organ specific. So high or increased ALT in a dog or a cat or a human being clearly says that it is a hepatic insult, a liver insult. The ALT in the cow is the GLDH. So GLDH can be considered as ALT in the cow. Glutamic dehydrogenase. It is liver-specific enzyme in the bovines. GGT can be considered as a liver-specific enzyme in the feline. Sorbitol dehydrogenase, GGT is glutamic gamma glutamyl transferase. Then SDH, sorbitol dehydrogenase. It can be considered as a liver-specific enzyme in the equines, so also the bovines. So most of these enzymes are present in almost all the somatic cells. For pinpointing, sometimes need isoenzyme estimation. Some enzymes have isoenzymes. For example, CPK, LDH. CPK and LDH have isoenzymes, daughter enzymes. And these enzymes will be distributed in specific parts. So we'll have to conduct electrophoretic study of each and every isoenzyme. Then only we can pinpoint with these enzymes. For example, CPK, another example is LDH. CPK is creatine phosphokinase. LDH is lactic dehydrogenase. Then species differences. ALT is found abundantly in liver of dogs. One thing you have to keep in mind is like ALT and AST. See, these are all new names of SGPT and SGOT. SGPT is ALT. SGOT is AST. SGPT is liver specific. That means ALT is liver. L liver. Okay, that's good. ALT, L is liver. Other thing. So ALT is found abundantly in the liver of dogs. Abundantly in the liver of dogs, cats, and human beings. In human beings, ALT is very important. As when the doctor considers ALT, it is very important. A simple hike, a light hike in the ALT itself will be considered very seriously in the human medicos. But abundant ALT is found in the muscle of horse. So can we consider ALT as liver specific in the horse? No, it is skeletal muscle specific. Let us see alanine transaminase ALT. The old name of ALT is SGPT. That SGPT means serum glutamyl pyruvate transaminase. So these are involved in transaminating reactions. These are high energy protein metabolism. We all know that proteins are being absorbed from the gut as such. Sorry, proteins are split into amino acids and absorbed. Sorry. Amino acids and absorbed. So these are the amino acids are absorbed. Amino acids are metabolized in the cells to produce ATP. So we have a lot of essential amino acids. Along with that, we have alanine. The alanine metabolism is very important. Alanine is being metabolized by this enzyme, alanine transaminase. And alanine is metabolized in high energy amino acid metabolism. Alanine is being metabolized and the end products are pyruvic acid and glutamic acid. So alanine is converted to pyruvic acid and glutamic acid by the help of this enzyme, this SGPT or ALT. Thereby, ATP is being released and stored. They have no isoenzymes. And their ALT is highly liver specific in the dog, cat, and humans. And I see I'm normal activity is below 50. I'm not telling about normal level. It is activity. So the normal activity should be below 50. That is ideal. It doesn't mean that if it is 52, it is not ideal. It is the liver is gone. No, nothing at all. If you give 1 or 2 or 3 doses of paracetamol in the human being and take the SGPT level be coming around 60, 70, 80. That doesn't mean that the liver is damaged. Another thing is ketoconazole. Ketoconazole is given to dogs. All imidazole derivatives, ketoconazole, griseofluid, fluconazole, itraconazole. All these are very potent hepatotoxic agents. So if these medicines are given, generally, slightly it will be ALT level rises up. And that when you stop the medication, it will get down. So the normal activity, generally it is up to 50 units per liter. So when there is severe or acute liver degenerations, it raises in thousands. But as a rule, in dogs, 100, 150 levels, etc., is significantly, we can say that there is liver involvement. 100, 150 levels, etc., gives a clear clue that the liver is involved. Then the AST, aspartate transaminase. Here, aspartic acid, that is the next essential amino acid, is being metabolized. Here, aspartic acid, the older name is SGOT. Aspartic acid is being metabolized by the route of high energy amino acid metabolism, and aspartic acid will be transaminated by this enzyme, producing oxaloacetic acid and alpha ketoglutarate acid. These are the end products by which ATP is being released. The thing is with the AST is found in almost all the organs. So if there is a hike in AST, we cannot say that there is a specific hike in any specific organ. We can say that there is degeneration somewhere in the body. But to a certain extent, a little portion is found, okay. Up to almost 15 to 20% of this enzyme is found in the liver. Of course, when the liver is involved, we can say there is hike in AST. But when you want to see whether the liver is involved, you have to see ALT plus AST. When you are taking the AST plus AST, if both are elevated, you can say that the liver is involved. If ALT is normal and AST is elevated, you can say that the liver is not involved, but there is degeneration somewhere in the body. Okay. Somewhere in the body, which we will have to find it out. And another thing is, a good portion of AST is found inside the erythrocytes. Or if erythrolysis occurs, AST will be distributed in abundant quantities in the blood. And so when you take the serum, AST will be very high. So erythrocytes have high amounts and AST level increases in erythrolysis. And AST, since it is a non-specific enzyme, it can be used as an adjunct in lot of degenerative diseases, whether it is pancreatic study or liver study or skeletal muscle study, whatever it be. AST can be used as an adjunct. Then alkaline phosphatase. It is widely distributed, but it is mainly produced from, as I said, mainly produced from the intrahepatic biliary canaliculi lining cells. So also a good amount is produced from the osteoblastic and osteoclastic activities. So whenever there is a hepatic destruction or a bile duct destruction or a cholangitis or cholangiohepatitis, alkaline phosphatase level increases. Another thing is that whenever there is a bone disease like osteosarcoma, then degenerative osteoarthropathies, then fractures, in these conditions, osteoblastic and osteoclastic activities will be more, producing more amount of alkaline phosphatase. In that condition also, the same thing happens, alkaline phosphatase level increases. What about in the growing bone? As I said, there will be increased osteoblastic and osteoclastic activities. And so during that time, there will be hike in alkaline phosphatase. Got it? So, what about the production of alkaline phosphatase inside the biliary canaliculi and through the mixed with the bile is flowing out through the bile duct into the duodenum. If there is an obstruction in the bile flow, obstructive cholangic diseases, obstructive cholangiopathies. Also, there will be hike in alkaline phosphatase. Obstructive biliary diseases. Then, some amount of alkaline phosphatase will be flown through the bile and passing through the intestines. It will be reabsorbed. If there is a stasis in the intestine, again, enormous quantities or increased quantities will be reabsorbed. And so the alkaline phosphatase level there also shows a hike. So alkaline phosphatase hike is shown in intestinal obstruction or intestinal wall degeneration such as parvoviral enteritis, parasitic damages, etc. And as I said, high in cholestasis and hyperadenocorticism. So all these conditions, alkaline phosphatase increases. Then it increases in hepatic and hepatobiliary damages. It is substantial. Degeneration except the bone and intestinal wall increases up to 1000 or so. If it is a bone pathology and cholestasis, it increases up to even 50,000. The activity is something around 50,000 in bone pathologies and cholestatic diseases. If it is showing the degeneration of the hepatic and biliary canaliculi, it can be in 1000 or so. The normal activity is some 300 or something, 300 units per liter. Then the CPK creatine phosphokinase. See, this is another enzyme, phosphocreatine phosphokinase, by which the muscle creatine or the protein, the creatine is being converted to creatinine, and the phosphorus substrate is given or kinase moving. That is the enzyme phosphokinase. This enzyme supplies a phosphate group for high energy protein metabolism. And this enzyme is found as a dimer. Only two molecules form a separate molecule of enzyme. So two subunits are there, the M subunit and the B subunit. Since they are found in dimers, there should be a combination like MM combination or MB combination or BB combination. This is very important. CPK MM, CPK MB, and CPK BB. CPK MM is widely distributed in skeletal muscles. CPK MB is widely distributed in cardiomyocytes. That is why in human heart attacks, what is happening? It is not like the heart attack in the dog. Heart attack in the dog and heart attack in the humans are entirely different. The humans, we get the heart attack due to blood vessel occlusion. That is ischemic heart diseases. That is the main cause of heart attack in human beings. But that is not the story in dogs. In dogs, it is chamber size disorders like dilated cardiomyopathy, or hypertrophic cardiomyopathy, or restricted cardiomyopathy, or congestive heart failure. Congestive heart failure is the outcome. Or sometimes in the dog, some conduction disorders occur, like the right bundle branch block or the left bundle branch block or the AV block occurs. That is all regarding the human heart attack, the dog heart attack. But in the humans, along with that, ischemic heart diseases are very common. So when there is ischemia, for example, coronary thrombosis or coronary artery defect or myocardial infarction in human beings, there will be myocardial ischemia, producing severe degeneration of myocardiocele. So what will happen when we are admitted to the hospital? They will take the CPK-MB level. That is very important because that is found only especially in the cardiomyocytes. Almost 95% of the CPK-MB in human beings and dogs are found in the cardiomyocytes. And CPK-MB isoenzyme can be said to be highly cardiomyocyte specific. In human beings, when they are in the CCU, the coronary cardiac center unit, coronary care unit, they will take the blood, take the serum for estimation of CPK-MB. It is highly specific. And CPK-BB, it is highly brain specific. CPK, almost 100% of the CPK-BB isoenzyme is seen in the neurocytes, that is the neurons. And so in the human neurology, CPK-BB is very important. Our neurology is not much well developed. So we can use the CPK-BB isoenzyme estimation. It can be estimated only through chemistry studies, immunofluorescent assays. So it can be, if possible, it can be used in distemper, current distemper studies. So the major share of the total enzyme is in the feline liver. Coming to the feline liver, if we take the total CPK, okay, of course, to a certain extent, it can be considered as liver specific, total CPK. In the dog, total CPK is not at all a good procedure. If we take the total CPK, it does nothing. It gives no idea. In human beings and the dog, we should take the CPK isoenzyme, like the CPK-MM or BB or CPK-MB. And CPK-MB is most important in the human beings. And CPK-BB is found only in the brain. Okay. It is a highly specific for muscle destruction, rhabdomyolysis in cattle, myositis in dogs, muscle trauma, cardiac ischemic injuries, iliac thrombosis in cats. Normal activity is approximately 100 units per level. Significant rise is up to almost 50,000 IU levels during damages. What is rhabdomyolysis? This question I asked to some of my internship trainees. I was asking, what is acute viral infectious rhabdomyolysis, bovine rhabdomyolysis? And they were hearing this acute infectious bovine rhabdomyolysis, acute infectious viral bovine rhabdomyolysis. I was asking this to my internship trainees and they were surprised. They have never studied of such a disease. This is nothing but ephemeral fever. So in ephemeral fever studies, lot of studies are there where CPK-MM was used. Then myositis in dogs. Severe myositis occurs in leptospirosis. Severe masticatory myositis in dogs. In masticatory myositis, there will be severe inflammation of the parotid, the masseter muscles, and the digastricus muscles. These are all chewing muscles, that is a masticatory muscles. So in that case, we can use CPK-MM. Then cardiac ischemic injuries in dogs or human beings. We can go for CPK-MB. Iliac thrombosis in cats. It is not so common, but it can occur. In such conditions, we can go for studies with CPK-MM. So the normal activity is something around 100 units per liter, but you should say that there is severe degeneration only when it rises up to 50,000 units or so. Then lactic dehydrogenase. This is another highly non-specific enzyme. We cannot do anything unless you are taking. See, I have spent a lot of money in estimating LDH because I was crazy after LDH once upon a time. Electrophoretic studies were conducted by me several times, spending a lot of money. So, LDH is a tetramer. The subunits are H unit and L unit. So, HH, 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 HL, HH, LL, HLLL, and LLLL, or LDH 125. LDH 1 is otherwise known as HBDH. HBDH is very commonly estimated in human beings. HBDH, hydroxybutyric dehydrogenase. This hydroxybutyric dehydrogenase, HBDH, is very commonly estimated in human beings in the coronary ICU because almost 100% of LDH1 or HBDH is distributed inside the cardiomyocytes. So when there is cardiomyocyte degeneration, HBDH level increases. This can be used in our condition also. The same thing happens in dog also. Then, so a very small, insignificant quantities are found in the kidneys and erythrocytes. LDH5 is found abundant in the liver. Here, my question itself is, why should we go for LDH5? Why should we go for expensive LDH5 studies, isoenzyme estimation, like erythrophoresis? Our ALT is there. ALT itself is enough. But for theoretical studies, LDH5 can be used. Others are found in skeletal muscles and lungs. Leave it. So LDH1 is the most important one. LDH1 is otherwise known as hydroxybutyric dehydrogenase, HBDH, which is found inside the cardiomyocyte. Normal activity is 200 to 300 units per liter. In damages, it increases to several thousands. Even in human medicine, total activity is not so significant since 5 isoenzymes are there. And there is no specificity because 5 isoenzymes are there, no specificity. So we can ignore that to a certain extent. And electrophoretic studies it is very expensive. We need not go after that. Then sorbitol dehydrogenase. Of course, to a certain extent, we can use this in dogs also. Catalyzes the conversion of D-fructose to D-sorbitol. Found abundant, but SDH is a liver-specific enzyme for the cow, goat, and the horse. I am not giving a class on equine or bovine medicine, but I was telling. And found abundant in the liver of cattle, horses, dogs, and other farm animals. So here also, SDH also, if money permits, we can go for SDH estimation also. It is an ALT substitute in horse and cat, of course. In dogs, we have more specific enzymes, like we have ALT, we have AST, even though it is not a non-specific, it is not a specific enzyme, we can go for it. Then another thing, we have LDH5, which is abundantly found in the liver. And normal activity is below 5 units per liter. Below 5 units. Then GLDH. GLDH is abundantly found in the liver of farm animals. So leave it. It is an ALT substitute in the ruminants. The normal activity ranges from 20 to 25 units per liter. In acute hepatic necrosis, sometimes it go above 100. GGT. GGT can be considered as a specific enzyme for the liver of cats and also the dog, like in the ALT, mainly in the liver and kidney. And in some areas where we have this kidney worm of dog, that is Diagnostic urine. Kidney worm of dog enters the kidney and they dig tunnels inside the liver and produce severe trauma inside the kidney. So in such conditions, if you go for GGT, it will be very high. And whenever there is a leakage, mostly instead of being absorbed by blood, the enzyme will be excreted through the urine because it is a kidney which is affected. And renal tubular necrosis, kidney worms, etc. It can be used to aid other LFTs. Of course, GGT, it is not too much costly. We can use GGT as a liver-specific enzyme. The normal activity is up to 60 units per liter in the dog, as well as in the cat. Amylase. And amylase, see, some of us believe that the saliva has some amylase in the dog. In some Indian textbooks also it is written. It is wrong. There is no salivary amylase in the dog. But salivary amylase, pancreatic amylase and intestinal amylase are there. And so in pancreatitis, the amylase level peaks up. That is 7 to 10 times it peaks up. When there is severe pain and abdominal vomiting, acute abdominal, then severe pain in acute pancreatitis, there will be severe pain, vomiting, diarrhea, etc. And even by touching the abdomen itself, the animal may growl and try to bite. Normal activity is almost up to 3,000 units per liter. In acute pancreatitis, it goes up to 5,000 to 50,000, even 50,000 levels. And amylase is not useful in cats. And amylase, after secretion from the pancreas, it flows into the duodenum via the bile duct. And so if there is an intestinal obstruction, there will be hike in amylase. Another thing is that amylase is chiefly excreted through the kidneys. And so if there is a renal impairment or there is a chronic kidney injury or acute kidney injury, chronic kidney disease, where the GFR is low, amylase cannot be excreted and there will be hike in amylase. I got a case, like it was a German Shepherd. I will show you the case here. Then lipase. Lipase is produced from the pancreas only. From nowhere lipase is produced. So lipase is highly pancreas specific. So when you suspect pancreas, go for the lipase only. You do not even take the amylase. Involved in hydrolysis of triglycerides. Normal range is about 300 units per liter. So lipase is highly specific to the pancreas. In pancreatitis, the level rises over 500, which is highly specific. Again, this is also not useful in cats. In the cats, you will have to go for immunoreactive trypsin, which is not available in our place. It may be available in other places, European countries or Macau or somewhere. So this lipase is also excreted through the kidneys. And so if there is a kidney disease or renal failure, high in or increased level of lipase can be seen. Immunoreactive trypsin, even though, so this is not found in, this is not estimated in Asian countries. Immunoreactive trypsin, probably the trypsin precursor or the trypsinogen is present in the serum or plasma and will react to anti-trypsin antibodies but has no proteolytic activity. Decreased trypsin-like immunoreactivity, TLI, indicates exocrine pancreatic insufficiency. And this is used in acute pancreatitis in cats. Then another important enzyme is acid phosphatase. Acid phosphatase, mainly it is produced from the prostate. Then some amount of seen in the RBCs, bones, platelet, etc. The only use of ACP in the dog is to assess the prostate. So we all know that the prostate diseases are commonly found in dogs, and especially BPH, benign prostatic hyperplasia. But in the human beings, there will be ACP hike, the increase in ACP in human beings with BPH. But in dogs, there is no increase of ACP in BPH. But ACP will be increased in dogs only in prostatic adenocarcinoma. Even if you explore the finger, so generally what we do, if you suspect if there is a ribbon-shaped feces in dogs with chronic obstipation and ribbon-shaped feces, what will we observe? We suspect that it could be prostatic enlargement. First, what we will do, with the forefinger, we will use to explore through the anus. We can touch the left and the right prostates. If there is an enlargement, we can palpate it to a certain extent. If the finger is much long as what I have. If it is a short finger, we cannot touch it. So even just pressing, just single one or two pressing on the prostate itself, ACP will be released outside and ACP will increase. That much sensitive is the pancreas. If you want to target the kidney, what all things we should have to look through? High urea, that is a blood urea or the serum urea. High creatinine. The creatinine is more sensitive than the urea. If you don't drink water for 1 day or for 8 hours and then take the blood urea level, it will be high, something around 60, 70. It doesn't mean that the kidney is damaged, but it is due to reduced plasma level of the blood. But creatinine, it is very sensitive. In dogs, the creatinine should not go beyond 1.5 milligram per deciliter. If it exceeds 2 itself, it shows that there is more than 50% damage to the kidneys. That is why it is always said that creatinine is not a clear indicator of kidney damage. Creatinine indicates kidney damage only when 75% of the kidney is gone. So, while we detect that the creatinine is very high, suppose it is 3, 4, etc., almost 75 to 80% of the kidney is damaged. How can we repair the kidney? We cannot. So, early detection of kidney disease is so important. For that, we use SDMA, symmetric dimethyl arginine. It is very sensitive. Just in 14 microgram per deciliter, above 14 microgram per deciliter itself is significant. It proves that if there is hike in SDMA, it proves that just it will be shown even in 25% damage, so that we can repair the kidney very soon. So nowadays, creatinine is not a big measure of kidney disease. And moderately high amylase and lipase, because I have already said that amylase and lipase are excreted through the kidneys, and if there is a kidney damage, amylase and lipase becomes very high. Urea or urine nitrogen increases in when there is increased, when there is eating more food, when there is increased protein catabolism such as fever, burns, corticosteroids administrations, corticosteroid administration, starvation, exercise, etc., there is increased protein catabolism. When there is increased protein in the ingestion or in the protein digestion, like in the case of hemorrhage into the gastrointestinal system, Hemorrhage contains a lot of protein, that is globin will be absorbed, high protein diets, etc. When decreased GFR, decreased glomerular filtration rate, as in the case of azotemia, that is increased NPN substances due to pre-renal causes, renal causes, or post-renal causes. Kidney failure. When there is kidney failure, there will be increase in urea, blood urea. Not that urea will be increased with the normal creatinine in the following situations. See, not that urea will be increased with a normal creatinine in the following situations. Urea can, see, a urea alone increasing will not say, cannot say that the kidney is involved, especially in increased protein, increased production of urea. Example in protein catabolism. If you are eating 30 or 40 eggs a day, excess protein metabolism happens and urea will be produced more, uric acid will be produced more. Early pre-renal azotemia, early kidney disease. Urea resorption, the proximal convertative, leave it. Urea, blood urea decreases when protein intake or protein catabolism, anabolism. Dietary restriction of protein, low protein diet, young animals with high anabolic rate, then increased excretion, increased excretion of proteins, any cause of polyuria. Example, hyperadenocorticism, diabetes mellitus. In all these conditions, there will be decrease in blood urea and decrease the production of blood urea like in liver diseases. Yeah. See, what is the end product of protein metabolism? It is nothing but uric acid. Uric acid will be taken up and it will be taken to the liver, and the liver detoxifies the uric acid to urea, and the urea immediately has to be excreted. Urea is less toxic than the uric acid. Uric acid is highly toxic. Uric acid, somehow it has to be detoxified to either either urea or allantoin. Generally in all the dogs, uric acid will be detoxified to urea with the enzyme uricase, which is present in the liver. In the Dalmatian, uricase enzyme is absent. So what will happen? Uric acid will be converted to another compound known as allantoin and excreted through the urine. Allantoin has certain properties. Allantoin precipitates more than urea. That is why kidney urinary stones are more in the Dalmatian. Another thing is, allantoin is having a very pungent smell, odor. That is why the Dalmatian urine is having a pungent odor. Okay. So, when there is a liver disease, uric acid cannot be converted to the urea, and so the blood urea level will decrease. Then the enzyme deficiency, for example, in the case of Dalmatian-like syndrome, uricase enzyme deficiency. Then the creatinine from normal muscle metabolism, phosphocreatine is converted to creatinine, then hydrolyzed to creatinine. Additionally, so for conversion of creatine to creatinine hydrolysis, we need the creatinine phosphokinase. Additionally, muscle creatinine in carnivores passed freely through the renal tubules, but in gut it is absorbed. So, in all animals except the gut, creatinine will be excreted through the renal tubules, but in the gut, creatinine will be reabsorbed. Changes in the GFR will not influence creatinine like in the urea, and so more significant and consistent than the urea. So whenever it is said in all textbooks, especially in the mercury manual, that if you are considering certain parameters to check the kidney, it is not the urea, blood urea, which is more important. This creatinine is very important. Any small alteration in creatinine itself, creatinine can cause or shows severe damage to the kidneys. That means we say that creatinine is more sensitive than the blood urea. And if you are targeting the lung, high urea. Why there is high urea in the lung? Ammonia cannot be excreted if the lung, there is a chronic lung disease. There is hypoventilation. And so ammonia is normally excreted through the expired air. And so there is a chronic lung disease, ammonia that cannot be too much excreted, and so it will be accumulated in the blood. Hyperammonemia occurs. Ammonemia will be converted to uric acid. Uric acid will be converted to urea, or high urea occurs in lung diseases. Normal here, there also normal creatinine occurs. High AST because there is a lung parenchyma disorder. High LDH, LDH 3 and 4 is found abundant in the lung. High CPK, normal ALT. ALT is found normally in the hepatic tissues. If you are targeting the brain is having a normal ALT, high AST. AST is a non-specific enzyme found everywhere. High CPK-BB. CPK-BB is found abundant in the brain. High LDH, total LDH. High GGT, normal alkaline phosphatase. Alkaline phosphatase has nothing to do with the brain. If you are targeting the heart, it has no ALT, normal ALT. It has high AST. AST is found everywhere. CPK total, CPK-MB is increased. LDH total is increased, but LDH1, that is HBDH, is increased. We already studied it. Liver, ALT in dogs and cats, acute to medial damage. See, ALT is a highly liver-specific enzyme in the dogs, cats, as well as the human beings. So if there is a hike in ALT, it shows that there is acute to medial damage of the liver. SDH, it shows that there is acute damage in the horse and the ruminant liver. So also SDH also can be used in the liver for assessing the liver of the dog and cat, especially the dog. GLDH, okay, you can say only in ruminants and horses. AST is a non-specific enzyme, acute or medial damage, but not liver specific. GGT, yes, it is liver specific. It can be considered as liver specific in dogs and cats, but ruminants also. Alkaline phosphatase can be considered as if there is a bile duct obstruction, if there is bile duct canalicular obstruction, if there is cholangiohepatopathy, cholangiohepatitis, then if there is fractures, osteosarcoma, any chronic bone diseases where there is more osteoblastic and osteoclastic activities, alkaline phosphatase increases. Or if there is a bile duct obstruction, then LDH as such is not very specific. Then we can go for, if there is, we are targeting the liver, go for albumin, prothrombin. See, all this we know very well. Albumin, take the albumin because albumin, the main seat of protein synthesis is the liver. From the liver, protein is being synthesized. Then prothrombin, synthesized in the liver. Urea, synthesized in the liver. Ammonia, metabolized in the liver. Bilirubin, conjugated in the liver. Bile acids, produced in the liver. Postprandial increase in bile acids in portosystemic shunting. I'm not describing all this because we have certain lack of time. Then, and the cholesterol, the main seat of cholesterol synthesis is the liver. There is no need of any dietary cholesterol even. 85% of the cholesterol is being synthesized in the liver. Then alkaline phosphatase can be used for assessing the liver condition. Then all these enzymes, liver-specific enzymes, can be used to assess jaundice. Of course, for assessing the jaundice, we take all the enzymes like the ALT, AST, alkaline phosphatase, GGT, etc. And we can even use this LDH5 for assessing jaundice. Especially, we have to, whenever we are meeting with the case of jaundice, what will we do? We have to ascertain whether it is a prehepatic or hepatocellular or a post-hepatic. We can go to the Vandenberg test or the estimation of conjugated bilirubin and unconjugated bilirubin. Then the hepatic diseases, biliary obstructions, we can go for alkaline phosphatase estimation. Then for the study of skeletal muscles, we can go for AST estimation. AST it is not a specific enzyme, but it is found abundant in the skeletal muscles also. High CPK-MM in skeletal muscles. CPK total, the normal ALT, but in the dog, ALT is not found in the skeletal muscle, but in the cow and the horse, ALT is found abundant in the skeletal muscles. Then the pancreas, we can go for the amylase, estimation of amylase. Amylase is not specific, of course. You can go for intestinal amylase also. We have two amylase, intestinal amylase and the pancreatic amylase. But lipase is highly sensitive. Lipase is produced from the pancreas only. Then ALT and AST increases. In pancreatic disorders, ALT and AST also increases, especially AST. Then immunoreactive trypsin. Immunoreactive trypsin especially is used in cats. Then exocrine pancreatic insufficiency. To detect exocrine pancreatic insufficiency, we can go for estimation of these enzymes, pancreatic amylase and pancreatic lipase. മതി മതി ഞാൻ താഴെ വരാം. Sorry, my wife was asking me whether what type of food I need for dinner. Okay, then for endocrine pancreatic insufficiency also, we can go for pancreatic tests. All these pancreatic tests, insulinoma, glucagonoma, etc. Then the small intestine, alkaline phosphatase and the AST. Alkaline phosphatase, as I said, it is produced from the cells of the biliary canaliculi and mixed with the bile and flown into the small intestine or the duodenum via the biliary tract. And when there is a small bowel obstruction, there will be stasis of the bile and all the bile will be reabsorbed, producing hike in alkaline phosphatase. So with the clinical signs, if you see hike in alkaline phosphatase, we can say there is small intestine obstruction. So also in the parvo, corona, etc., there will be destruction of the mucosa of the small intestine. Then there will be hike in the alkyl phosphatase. So the alkyl phosphatase is the only enzymes, ALP and the AST are the only enzymes which can be used for studying the small intestine. They are studying the musculoskeletal system, the bones. We know the relationship between the bones and the alkyl phosphatase. Then CPK, AST, LDH, etc. can be used. These are some of the normal activities. These are not normal values, normal activities. CPK total, the normal activity is 100 units per liter. LDH total is 200 to 300 units per liter. ALT in the dog, these are all in the dog. ALT in the dog is 30 to 50 units per liter. SDH is below 5 units per liter, normal. GLDH is 20 to 25 units per liter. GGT is 60 units per liter. Alkaline phosphatase should be below 300 units per liter. Amylase should be below 3000 units per liter. Lipase should be below 300 units per liter. Acid phosphatase should be below 30 units per liter. These are the normal levels of commonly used enzymes in canine medicine. Then ultimately thyroid. These are not enzymes, but T4 is the most reliable one, and T4 is expressed as total T4 and free T4. The normal level of total T4 is 1.5 to 4 micrograms per deciliter, and free T4 is expressed in nanograms as well as picomoles per deciliter. If it is just take it down or take a photograph of all these things or take a screenshot, because this is very useful. If it is expressed in free T4, if it is expressed in nanograms, the normal level is 0.7 to 3.7 nanograms per deciliter. And if it is expressed in picomoles, the normal level is 9 to 47 picomoles per deciliter. And the TSH normal level is 0.05 to 0.42. And thyroglobulin autoimmune antibodies. Autoimmune thyroiditis is very common, and TGAA is the enzyme which is protein which is estimated, and this protein should be below 20% in a normal thyroid. If it is above 20%, we can say it is autoimmune thyroiditis. And hypothyroidism is very uncommon in the cat and normally cannot be found. But hyperthyroidism is the commonest thyroid dysfunction in the cat, and T4 increases up to 50 nanograms or so. That is something regarding thyroid. Let me tell you regarding 3 cases. One case, it was a Labrador male intact 6 years, presented with vomiting for 2 days, had been on Visolon, that is prednisolone acetate tablet for 5 days against contact allergy dermatitis, and it was having a congested mucous membranes, moderately dehydrated, swollen lymph nodes, had a pruritus, and it reduced after tablet administration. Quite normal because it is having CAD, contact allergy dermatitis. So the total leukocytic count was 28,000, is very high. DC neutrophil is normal, lymphocyte is normal. ESR is 74, which is very high. ALT is very high. AST is very high. So see, all these things. CPK is normal. Alkaline phosphatase is very high. Creatinine is normal. Blood urea is normal. Potassium is normal. Or we can say slightly hypokalemic, maybe due to vomiting. So what this was? It was steroid-induced hepatopathy. And how I diagnosed it, I withdrew all the corticosteroids because it is well evident it is steroid-induced hepatitis. Withdrew all the corticosteroids, IV fluids, and oral hepatic regeneratives were given. There was complete resolution. And the second case, GSD. This was a very, very interesting case. This was attended by me and my friend, Dr. Rajesh. 10-year-old German Shepherd, old intact geriatric male. So how we can say a dog is geriatric? If the dog is geriatric, if the dog is about 10 kilograms, if the dog is about 10 years of age, and if it is about 10 kilograms, we can say it is geriatric. But it should be about 10 kilograms. If it is below 10 kilograms, it should be about 12 years to say it is geriatric. Got it? If it is about 10 kilograms, of course, we can say after 10 years it becomes geriatric. But if it is below 10 kilograms, suppose if it is a Pekingese, it is 7 or 8 kilograms Pekingese. If he is 10 years old, it is not a geriatric dog. In toy dogs below 10 years of age, if it is above, if it is 10 toy dogs below 10 kilograms body weight, it can be said as a geriatric dog if it is above 12 years only. If it is below 12 years, it cannot be told as a geriatric dog. That is a very interesting term. Then this is German Shepherd, which is not a geriatric but old intact male, vomited and recommended for 3 days. It is having continuous vomiting. And some management was given somewhere with antibiotics or so. Completely akinetic. The dog is moving, not moving. Only this respiration is there. Pulse is very weak with dehydration. Recombinant very weak. Feeble responses. Reflexes were all feeble. Stool and urine pass normally. Temperature, pulse, respiration is normal, somewhat normal. ALT level was very high. AST level was very high. Alkaline phosphatase was almost normal. Amylase was extremely high. Lipase was very high. Glucose random was high. Creatinine was very high. blood urine nitrogen was high, very high, total leukocytic count, severe leukocytosis with degenerative shift left, and differential count, severe neutrophilia. What it could be? First, see, after going through all these values, high lipase, high amylase, high AST, high ALT, and we thought that, see, total leukocytic count is 32,000. Okay, creatinine burn is high. Okay, kidney is gone. Myself and my friend thought it is acute pancreatitis. And assuming that it is acute pancreatitis, we started the treatment. And then during that, it was long, 20 years back, 15 years back. And there was no response in 2-3 days. And we discussed with some stalwarts and also some human doctors. They all said that when amylase is high and lipase is high, along with kidney failure, you will have to consider that there is no pancreatitis, but the hike in amylase and lipase is due to the kidney failure. This we referred in Merck veterinary manual and we found correct. And we were mistaken. It was not pancreatitis. The increased amylase and lipase level was due to kidney shutdown, renal shutdown. And ultimately it was concluded that it is an acute renal failure, chronic kidney disease, and no urine was forming at last. No urine was there. No urine. The bladder was absolutely empty. That is complete renal shutdown. And the dog was euthanized. Even though I don't know whether it is acute kidney, but these people, the owner says that it has been there for so many days, and it was having urinary infections for almost one month or so. The third case, German Spitz, 6 years old intact male, acute vomiting and prostration. With the diarrhea, and it was febrile, swollen abdomen, pain on palpation of the abdomen, anorexia, dyspepsia, moderate dehydration, congested mucosa, history of mating 3 days ago. This just for confusion, history of mating 3 days ago. But all these clinical signs itself prove that there is some pain inside the abdomen. See the total leukocytic count, very high, severe leukocytosis, very high neutrophilia, 89%. ALT is very high, AST is very high, alkyl phosphatase is high, amylase is extremely high, lipase, it is very high, extremely high. Lipase is very sensitive, lipase is very sensitive. Protein, normal protein, albumin, normal albumin, calcium is also normal calcium. So this was acute pancreatitis. And I saved this animal. I don't have the photographs. I saved this animal. So I think with this, we are concluding the enzymatic studies. I took only certain very simple enzymes and only a very few numerable, just 10 enzymes. That is all what is needed for our routine use. No need for studying so many enzymes and studying all these rubbish things and get confused. So with this, I'm moving to the last session, that is interpretation, urine interpretation. This is also very important, urine biochemistry. Mostly, we veterinary doctors, mostly we are reluctant to collect the urine because, it is a very hectic procedure or a very difficult procedure, especially if it is a female. It will become a very difficult procedure to collect the urine. That is why we mostly are hesitant to collect the urine and do the test, perform the test in urine. But it is very simple. It is very simple to catheterize a female, especially if it is a big dog. When it's small breeds, very miniature pincher, etc., it will be very difficult for us, female catheterization. But if it's an adult Labrador, adult German Shepherd, Rottweiler, etc., it is very easy. Just by practice, we can introduce even the flexible urinary catheter can be introduced, and the urine can be collected. And when the urine is collected, the urine has to be examined in 1 hour. That is the main problem. If you are keeping the urine for a long time, so many biochemical changes occur and everything will go erroneous. Okay, let me start. Color, transparency, order, specific gravity, pH, proteins, glucose, ketone bodies, blood, bile pigments, and bile salts. These are the priorities of our urine examination. Let's just take one by one. Color. Normally, the urine is colorless. We all know normally it's colorless, or sometimes it may be slight yellow. If there is slight oliguria, maybe slight yellow, or straw colored. We can say straw colored urine. Sometimes the urine may be red in color. If it is red in color, we can say it is blood mixed. Or sometimes blood as such. If there is a severe trauma in the urinary tract of the bladder, if there are severe stones inside the bladder, puncturing the bladder mucosa, frank bleeding occurs inside the mucosa, and blood will be coming out. If there are polyps or TCC, especially very large cauliflower-like growths inside the bladder, transition cell carcinoma, be profusely bleeding, blood may come out. So those things, blood as such may come, or blood mixed urine can come out, or slightly blood tinged urine can come out. Blood mixed and blood tinged urine means it can be blood tinged urine, especially it is could be presence of stones. We have to find it out. Go for examination for crystals, or scan for solid stones inside the bladder, or inquire for urinary obstructions, dysuria, stranguria, etc. So blood as such means we'll have to go for ultrasonography. It is invariably needed. Ultrasonography. I have found polyps, multiple polyps and single polyps. I have found TCC several times, 4 or 5 times. Then red colored urine can be centrifuged. Whenever there is a red colored urine, we do not know whether it is hemoglobinuria or hematuria. We can take the blood, you can centrifuge it. If the centrifuged urine is taken out, and if there is a red color at the top and all the cells can be seen settled down, it is hemoglobinuria. If all the cells are settled down and the model top you can see the clear urine, it is hematuria. That is how we can distinguish hematuria and hemoglobinuria. Sometimes dark red or black color can be seen in myoglobinuria. Excessive destruction due to excessive muscle tissue breakdown produces myoglobinuria. Yellow color is normal because xanthochrome pigments give the yellow color to the urine. And if bile pigments are there, yellow color will be more deep. And we say it is icteruria. And sometimes deep yellow color is misinterpreted as red color. That also can happen. For example, the dog is not drinking any water at all, or there is a concentrated urine of that sort. It is not eating food for the last 1 week, very weak, and the urine be too much concentrated. Deep yellow color. Sometimes the owner will be saying that there is red colored urine. Then, if it is having severe diuresis, diabetes mellitus, if it is under diuretic therapy, furosemide, or if there is diabetes mellitus, or if there is diabetes insipidus, or if there is Cushing syndrome, it is urinating all the time. Or if it is under corticosteroid therapy, there will be a transient hyperglycemia. There will be increased urine formation. So when there is diuresis, mostly urine will be colorless. And urine becomes milky. Urine will become scanty, turbid in pus mixed urine. It is very obvious, it can be seen. Or when you take a sample of urine, it can be seen. So that is known as pyuria. So that shows the color of the urine. Then transparency of the urine. When it becomes turbid, the transparency will be lost. So the increased cellularity, transparency will be lost. Increased cellularity can be seen either in infection or in hemoglobin or hematuria or hemoglobinuria. Increased cellularity can be seen in infections, so also in tumors, PCC, etc. In pyuria, there will be turbid urine. Urine be almost semi-opaque in nature. Or even there is excess of myoglobin or RBCs. We can see opaque urine, non-transparent urine. You'll have to find it out so that the cause can be identified. Order of the urine. Who is going to smell the urine? Nobody is going to smell the urine. But when we take the urine, we can find some super offensive ammoniacal smell. Normally, in dog urine will be slightly ammoniacal, especially the cat urine will be highly ammoniacal in nature because cat is a complete 100% non-vegetarian animal. And if there is a polyuria, there is no smell at all. More ammoniac smell in concentrated urine in oliguria. When there is a concentrated urine or there is oliguria, there will be more ammoniacal smell. In dehydration, Addison's disease, renal failure, urethral obstruction, FLTD in cats, urinary tract infections, etc., there will be more concentrated urine and there will be more ammoniacal odor. Pungent odor in infections, yes, because of the chemical materials in the urine. Ammoniac odor in heavy meat diet, yes, that you can understand very well. Normally pungent and offensive in Dalmatians because, as I have told, in Dalmatians, uric acid will be converted to allantoin, and allantoin is having a pungent odor. Veterinarians should be beware of veterinarians should beware of Dalmatian and Dachshund urine, because when Dachshund and Dalmatian dogs, they urinate on our pants or our churidar or our shirt, then it is better we will burn it off, because I have burned 2-3 pants after the dogs have urinated on those pants, and that smell will be there for months together. Anybody can identify it. Then fruity odor in diabetic ketoacidosis due to ketone bodies. Those are the different order of urine. The specific gravity is very important. Average specific gravity throughout the day should be below 1.02 in dogs. Then the normal specific gravity, we can say it should be below 1.030 in samples of the first morning urine before food or water consumption. Ideally, the specific gravity should be 1.020 to 1.030. That is a normal specific gravity. If the specific gravity of the urine increases, we say it is a concentrated urine in oliguria. And if the specific gravity of the urine decreases, we say it is a dilute urine. It could be polyuria. And specific gravity of urine in some dogs may widely vary throughout the day as a result of too much of eating, drinking, and activities. Yes. And normal specific gravity is known as isosthenuric urine, isostenuria. And if it is having a reduced specific gravity is known as hypostenuric urine, hypostenuria. Then if it is having high specific gravity is known as hyperstenuria, hyperstenuria. Hypostenuria occurs in polyuria in diabetes mellitus, diabetes insipidus, polyuric kidney failure. When hyperstenuria occurs in dehydration, oliguric kidney failure, Addison's disease, these are very commonly found. Dehydration, dehydration specific gravity, because we have a urinometer. We can put the urinometer in the urine and we can detect the specific gravity of the urine if needed. The pH of urine. The normal pH should be acidic. It is a carnivore. Should be something around 7 or below 7. 5 to 8 is ideal, but it should be below 7. That is more ideal. Usually it will not change. pH increases to the alkaline side in urinary tract infection. High meat diet acidifies the urine. Citrus fruits, the lemon, etc., lemon, orange, etc., vegetables and dairy products alkalinizes the urine. So high meat diet acidifies the urine. Citrus fruits, vegetables and dairy products alkalinizes the urine. Calcium oxalate crystals form in low acidic pH. So these are the commonest stones: calcium oxalate stone and struvite stone. These are the commonest stone. Calcium oxalate forms in low pH and struvite stone forms in high pH, that is alkaline pH. Then proteinuria. Proteins will be excreted to the urine in dehydration. Proteins will be excreted to the urine through intense exercises. And albumin is the most commonly excreted protein in the urine. Protein-losing nephropathy such as glomerular nephritis and tubular nephritis. Then in early glomerular disease, etc., proteinuria occurs. Tubular destruction also. In pregnancy, especially in human beings, this is very significant. The fetus, the big bump of the fetus can press the renal artery, producing ischemia to renal artery, kidneys, and thereby producing proteinuria. Then some immune diseases also, especially in systemic lupus erythematosus, discoid lupus erythematosus, etc., proteinuria occurs. Then malignancies such as multiple myeloma. Multiple myeloma is not very common in dogs, but I have found one case. Dr. Nagendra Gupta from Lucknow has identified one case of multiple myeloma in a dog. So in multiple myeloma, if we suspect continuous and easy fractures with specific radiographic findings, we can go for estimation of Bence-Jones proteins in urine. That is known as myeloma proteins that can be detected in urine, and if it is positive for Bence-Jones proteins, it is multiple myeloma. Then glucose. Presence of glucose in the urine is glycosuria, produced in diabetes mellitus. Then primary or secondary diabetes mellitus, for example, Cushing syndrome, produces secondary diabetes mellitus. Diabetes mellitus of any cause, like insulin-dependent diabetes mellitus or non-insulin dependent diabetes mellitus. In both the conditions, glycosuria occurs. Early or mid-stage kidney diseases, rabies and distemper. See, once upon a time when I was studying in veterinary college, a dog was presented suspecting dumb rabies. And my professor asked me to take a kidney tray, a clean kidney tray. And I washed a kidney tray and took. He pressed the bladder and he expressed some urine out. He asked me to go and have a qualitative estimation of glucose in the urine. During that time, I didn't know what the idea was. And I did the glucose test. It was positive for glucose. He said that this is how we diagnose dumb rabies in the field. In rabies, there will be glycosuria. In distemper, there will be glycosuria. In lead poisoning, there will be glycosuria. So if we suspect, see, dumb rabies are very common, especially in India. India is endemic. Sri Lanka, it is also there. It's endemic. Pakistan, Burma, Bangladesh, Nepal, in all these places, rabies is endemic. So we'll have to suspect dumb rabies at any time. When it is presented, nothing will happen. We press the bladder, take out the urine, or catheterize and take the urine. Or even sometimes we can go for cystosynthesis and take the urine and go for glucose qualitative estimation. If it is positive for glucose, of course it could be rabies. But if it is negative for glucose, it is not rabies. That is the thing. That is what we can assess. If it is negative for glucose, it is not rabies. Then adrenal tumor. In pheochromocytoma, adrenal tumor, we can say there is glycosuria, some pancreatic neoplasia plus the glucagonoma. Glucagon inhibits, have a negative inhibition over insulin, and so glucose will not be metabolized, producing glycosuria. Ketone bodies are found only in diabetes mellitus. And the advanced case of diabetes mellitus is diabetic ketoacidosis. Then blood in urine. If there is blood in urine, it should be differentiated between hematuria and hemoglobinuria by centrifugation. And hematuria occurs due to bladder stones, kidney stones, urethral stones, urinary infections, bladder tumors such as polyps, transitional cell carcinoma, kidney worm, etc. All these conditions can produce hematuria. So generally, we are meeting all these cases in our routine practice. Bladder, kidney stones, urethral obstruction, infections, bladder tumors, etc. Hemoglobinuria can be produced by systemic disorders such as infectious or non-infectious systemic disorders. Systemic infectious disorders such as leptospirosis, various vector-borne diseases such as Babesia canis, Babesia gibsoni, then ehrlichiosis, erythrozoonosis, that is mycoplasmosis. Then non-infectious diseases such as IMHA, snake bites, any other DICs, etc. can produce non-infectious hemoglobinuria produced by intravascular hemolysis. Bile salts and bile pigments. Normally, traces of bile salts and then Dr. Vaivo. Thank you, Dr. Vaivo. Then Dr. Arukala Balakrishna. Dr. Balakrishna, there are a lot of textbooks, reference textbooks are there. The simplest textbook is Dr. Ganti A. Shastri's simple textbook. Laboratory techniques by Dr. Ganti A. Shastri. And so many other e-books are also there. I can give it to you in person.
So there are few
No more.
questions in the
No.
chat box also. Sir, do we get changes in values of blood test if the EDTA vial is overfilled?
Where is it written? I'm not seeing it.
It's while ago, sir. The, the question is if EDTA vial is overfilled, is there any changes in the blood test values?
No, nothing.
Okay, sir.
Nothing will happen.
Then next thing, how to identify anaplasma platis?
Anaplasma platis is found inside the platelet. Inside the platelet, it is another topic. It is vector-borne disease topic. We can find that it is anaplasma platis produces cyclic thrombocytopenia. Cyclic thrombocytopenia, it can be seen inside the platelet. It can be seen as small, clearly observed, round, purplish inclusion bodies in the cytoplasm of the platelet. It is very difficult to see because platelet is only 1/10 of the RBC. And inside the platelet, we have to see it. Very difficult to see. Of course, if you are able to see, that's good.
The next question is, sir, can we depend on human auto hematology and biochemistry analysis for canine and feline blood sample
Yes.
and serum samples?
Yes. First of all, let me say cell counts. The cell counts like the total RBC, total WBC, and differential count. These are the main three parameters which we cannot completely depend on human machines. We can just three parameters: total RBC, total WBC, and differential count. If possible, we have to use veterinary specific machines. Otherwise, we can go for a counting chamber, especially at least for DC. We can go. Otherwise, for the rest of the things like hemoglobin, then MCV, MCH, MCHC, etc. All those things are same as in then ESR, RDW. All these things are the same as that the human as well as the veterinary machines. But there is change. If at all there is a change, there is change only in RBC, WBC, and DC. And all other things like the blood biochemistry, ALT, AST, CPK, LDH, CPN, all these things are the very same as in the human as well as the animal. Then the urine biochemistry, the very same only, the very same.
The next question is, what is NT-PRO-BNP?
That is I see. I was wondering what this is. I want to say I don't know what it is. I don't.
Okay, sir.
Hmm.
Then which is more sensitive total of free T4? I think you already answered that question, sir.
I've seen one question. Dr. Swayam Prakash Nayak. Can you
Yes.
suggest and clarify what thyroid function tests in dog in human pathology suffering from hypothyroidism or responding to thyroid tablet therapy? It doesn't match the test result to symptoms and clinical signs are there for a hypothyroid dose. See, actually, free thyroxine is the most significant finding of what we can do in dogs. But in the human beings, total T4 is usually expected with the total T4 itself. But the human thyroxine and the dog thyroxine have specific certain differences. And the human machine, there are certain slight biochemical differences also. That is why mostly if you take the thyroxine level, total T4 now, and you take the total T4 after 2 hours, there will be a slight difference. That is what is happening. But generally in free T4, this will not happen. That is, there is no change in free T4. That is why it is always said when you are estimating the thyroid or the thyroxine level of the dog, it is better to estimate the free T4. Free T4 is somewhat more stable than in the humans. And the dose also is entirely different. In the humans, the dose is 1 microgram per kg. And in the dog, the thyroxine dose is 20 microgram per kg per day. So many of differences are there.
Another question is there, SDMA is a specific test. Can we rely on the diagnostic results from the human laboratory? So otherwise, always we have to go for animal specific blood analysis. I think there are two
See,
questions. SDMA is a species specific test.
yes, SDMA, actually, SDMA is not being spreaded and not being used by a lot of veterinarians. See, according to the veterinary specific tests, only IDEX machines have the SDMA test. None of the other veterinary machines have this SDMA test. And SDMA test, another peculiarity is it is very costly and it has a high specificity in animals. It is not being usually done in human beings. And as been said, it is said by all textbooks, even in the most modern, the most recent Merck veterinary manual also, SDMA is the most sensitive test where the kidney can be assessed. As when 25 is just by 25% destruction of renal tubules can show hike in SDMA, whereas creatinine level shows only 70 after 75% destruction of tubules.
Thank you, sir. Sir, what is the next question is what is the reason for glucosuria in rabies and CP?
Like Surya. See, in human beings, there are 3 types of cells in the body, like the somatic cells, the germ cells, and the nerve cells. And intense metabolism is being functioning in the nerve cells. Like the main glucose is being metabolized in all the cells by so many metabolic processes. The main metabolic processes are the glycolytic pathway, the Krebs cycle, and the pentose phosphate pathway. In the glycolytic pathway, in the somatic cell, like in all somatocytes, except the nerve cells, the somatic cells and the germ cells, glucose is being metabolized through the glycolytic pathway and the Krebs cycle only. But in the neurons, glucose is being metabolized mainly by the pentose phosphate pathway. Pentose phosphate pathway. Thereby, see this glycolytic cycle and Krebs cycle is also there in the neurons, but mainly glucose is being metabolized by the pentose phosphate pathway. We all know that the brain cells are the cells which need lot of glucose because brain is a powerful master organ of the brain, controls everything. And when glucose reaches the brain and the glucose is being metabolized through the glycolytic pathway Krebs cycle, but the majority is being metabolized through the pentose phosphate pathway. When there is a metabolic arrest or then when there is destruction of neurocytes, this glucose cannot be metabolized and all the glucose will be accumulated in the brain cells or the brain supporting tissues. And this glycosuria, there will be a transient glycosuria or a pathological glycosuria. And due to this glycosuria, this hyperglycemia, there will be glycosuria. And that is the reason for glycosuria due to neurological disturbances. I think you are clear.
Thank you, sir. Now next questions are over. Dr. Kalpana, are you there?
Yes.
Yeah, Dr. Kalpana.
Yes.
Hi.
Hi, sir. So today, actually, I would like to express my gratitude to Dr. Vinod Kumar, sir, for sharing his excellent knowledge with us. actually the topics are very interesting and it was not boring during 3 hours. So thank you so much, sir, for sharing your excellent knowledge with us. And also, I would like to thank FarmChem Private Limited for uh, contribute for their financial contribution. And also, I would like to thank all the participant veterinary surgeons from Sri Lanka and India. So thank you so much for everyone and good night to all.
Thank you very much. Thank you very much. Thank you, Kalpana.
Thank you very much.
Thank you, sir. Yeah.
So you excellent.
Thank you, Dr. Sagara.
Yeah.
Thank you, Dr. Mahesh,
Thank you.
for being here for so much of time. So much of time. Dr. Sagara, we know that Dr. Sagara is running a very busy hospital.